Hi, good evening. ज्यादा आवाज ही नहीं करना, बस तोड़ फाड़ नहीं, उसके अलावा कोई फर्क नहीं पड़ता। मतलब पांडे पुंड टंग 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 टंग। वो किस लिए, क्यों धोनी? और मैं उसमें डाल दूंगा, उसमें रिलैक्स ही रिलैक्स क्या करने हैं? नहीं, उसमें डाल देंगे, खत्म।
Good evening.
Good evening, Archana ma'am.
Hi, good evening, Kuldeep. How are you?
बिल्कुल बढ़िया.
How many अभी कितने स्टूडेंट्स पढ़ा दिए बताओ? 5,000, 10,000, 25,000?
नहीं नहीं इतने नहीं मैम.
You are a great teacher. Everybody like Girija said, "Oh, I saw Kuldeep's name." So मैंने कहा, "Yes, Kuldeep is here."
Thank you,
अरे
thank you.
you have created an खुद एक वो हो गए हो क्या बोलते हैं उसको इंस्टीट्यूशन.
Touch wood मैम. आप लोग सबने जो इस तरीके से किया तभी हो पाया मैम. That is why it was possible.
I know, but it's like a Kuldeep institution now.
नहीं मैम नहीं. Hi, Dr. Manila, how are you?
Yeah, sir, I'm good. How are you? It's great to see you. And we were
बिल्कुल
so excited that you, as a radiologist, is on the panel. So that's wonderful participation.
Thank you,
मैंने
thank you. Hi,
मैंने
Rupali, how are
इसीलिए
you?
लिया था.
Hello, sir. Good evening, ma'am. Good evening, Dr. Manila, ma'am.
Yeah, hi,
All
Rupali.
set. We're all set for today's event.
Yes.
Yes.
Let's hope.
It's really, we are very lucky to have Kuldeep sir also on board.
सब बोल रहे थे पोस्ट दिवाली. मैंने कहा यार हमारी तो आरसीओजी ने दो रख लिए हैं.
हाँ और दोनों अच्छे टॉपिक्स है मैडम, बहुत अच्छे टॉपिक्स है.
HPV वाला इज आल्सो वेरी
वो
गुड.
हाँ HPV सर्वाइकल पैप्स है ना, तो वो भी अच्छा है. एक्चुअली डॉक्टर अंजू हजारी मैडम मिले थे, तभी बात हुई थी कि अपना 24th को है, बट आई थिंक दे मे आल्सो बी हैविंग ऑन द सेम डे. 8 o'clock को है उनका.
आ गए क्या शीला मैडम? Sheila madam and Kore sir, I reminded them in the morning. I called them up.
Yes, I think we are having
8 people are there, 9.
अपने फैकल्टीज ज्वाइन नहीं हुए अभी तक.
मैम
अर्चना
फैकल्टी
मैम जब आपने पहले भेजा था ना तो आपने उस पे शायद 22nd लिखा होता है. दैट इज व्हाई आई वाज कंफ्यूज्ड.
Oh,
मुझे लगा था कि 22nd है. 24th है जब आया ना 24th एंड आई
हाँ.
वाज रेडी ऑन द 22nd. मैंने कहा बट दिवाली के जस्ट बाद कौन कौन आएगा. और 24th मैंने कहा कोई दिक्कत नहीं. नाउ देयर विल बी मेनी पीपल.
When it is Dr. Archana Baser, madam, anything is possible.
एब्सोल्युटली.
because इसने रूपाली was like, madam next month करते हैं. मैंने कहा नहीं, we are not going to miss our month. अपना अक्टूबर है.
She makes me get up from my slumber. Ki get up, you can't rest. No. And I love you for that. I can exploit myself also totally.
Thank you so much. Like Manila, I called up. Manila was I think traveling somewhere. I told her, said madam, I'll be back on this date. मैंने कहा back तो क्या, अभी WhatsApp चालू है ना काम.
And we did it, no? I came and I did a panel as well. दोनों काम हो गए.
Manila ma'am का तो बहुत help होता है, बहुत ज़्यादा.
You did. This show is all yours. I was just on the name.
Helps a lot.
She's a great academician.
Yes.
Well-read person.
Yes. We
So,
are.
yeah. So, I mean, we are all set with the flow of events, right?
Yes.
So let's just, we are waiting for chief guest and guest of honor. Should we call them and then Sudeep ji can give us the countdown and we can begin?
Yes, ma'am. 7 o'clock is already there.
मैं call करती हूँ. I'll call you.
तुमने Rupali, did you call our Purnima or not?
पूर्णिमा मैम को फोन नहीं किया, मैं कर देती हूँ अभी फोन. हाँ.
Purnima को किस?
I'll call Dr. Sheila Mane and Dr. This Shailesh Kore sir और पूर्णिमा मैम को कॉल करती हूँ. I'll get back.
Should I call Dr. Anusha? करूँ
Yeah.
मैं कॉल? Chairperson side call है ना?
करके हम वो कर लेते हैं. We have to start one time. I think Geeta is here. I can see Geeta. I can see Dr. Shailesh Kore.
Yes.
शैलेश सर भी आए हैं.
Yeah.
Geeta is here.
Dr. Meena Gauri ma'am is here.
गिरिजा भी आ गई हैं. Dr. Girija. She's driving somewhere. ऐसे लग रहा है गिरिजा going home from work.
Yeah. अरे नहीं, there was an electricity problem in my clinic, so I'm going to my home. But I'm here, so that's what I said a message in the group that I'll connect from the phone, and once I reach in electricity place, I'll connect on the laptop. Okay.
Okay. Great.
Best of luck for the webinar. Bye bye.
Thank you, Girija. Thank you so much. Hi, Dr. Shailesh. How are you?
Hi, hi, how are you?
I'm good. You remember I
Hi.
wrote a chapter for your
Yeah. I know. Of course,
twins.
I know. Yeah.
Yes. And I missed meeting you in recent meeting when there was a meeting, I think managing committee meeting. You just came and then we couldn't just meet
Yeah.
personally, but I just saw you coming and going there. So how is everything in Mumbai? You are taking over as a president of a big
Yeah.
society.
Yes.
When is it happening? March.
April. The date is not, means myself and Rajendra will finalize the date.
Okay.
Second week of April mostly.
Okay. I thought it
Okay.
is usually in your annual conference. No, nothing like that.
No. The last time it was on 20th April. So somewhere around 1 year after.
Same,
Yeah.
same day. Hi, Anusha. How are you?
Hello, ma'am.
Good to
I'm
connect
good.
with
How are you?
you again
Yes.
after RCOG. Yes,
Yes.
I did tell Rupali that yes, involve Anusha because we just recently met, so it like bond gets more thicker, like you meet more frequently.
Absolutely, madam.
Yeah,
Pleasure meeting you.
same here. Hi, Dr. Meera. How are you?
I'm great, ma'am. Thank you so much. Lovely to see all of you. Beautiful smiles.
I know.
Thank you for the opportunity. Thank you.
Thank you for joining and accepting.
Thank you, ma'am.
Yes, I think now we have only Sheila Mane ma'am is remaining, but we have Dr. Shailesh, so we can Dr. Rupali. Can we
Good
start?
evening, Dr. Shailesh. How are you?
Hi, hello sir. How are you?
बिल्कुल बढ़िया, बिल्कुल
Yeah,
बढ़िया.
all well.
So good evening, Dr. Sailesh, Dr. Manila from Indore. Namaste, sir.
Good evening, Dr. Salish, Dr. Anusha from Hyderabad.
Yeah,
Hi, Dr.
welcome, Dr.
Anusha. How are
Anusha.
you?
Hello, Dr. Manila.
Yeah, hi. So Dr. Rupali, shall we count down?
Yeah, I think Dr. Sheila Mane is somebody's.
Maybe Dr. Rupali is talking to her.
Okay.
Dr. Anusha is from where, ji?
Sorry.
Archana? Hi, Dr. Anusha.
Hello, Dr. Kuldeep. How are you?
बिल्कुल बढ़िया.
I've heard a lot about you, meeting you for the first time through an online webinar. I am from AIMS, Hyderabad. So I work as a faculty here. Nice meeting you through this session.
It's going to be good fun. मजा आएगा. गिरजा मैम ने क्वेश्चंस भी ऐसे मस्त बनाए ना, तो that's going to be good fun.
I think Sheila Mane might be.
Okay. All right. Okay. Archana ma'am, we are waiting for Dr. Purnima to join.
Okay. No problem. So yeah, we can just have an informal just talks then by the time everybody is joining, right? Dr. Purnima is joining.
Yes, ma'am. She just received the this link, so she's trying to connect. And if you say we can start, but
Dr.
Dr.
Sheila
Rupali told ki why not to wait for some time.
and Dr. Sheila.
Whatever you say, ma'am.
नहीं ठीक है ना Dr. Sheila Mane.
She's not picking up call, ma'am, for now.
Okay. Just wait for another 2-3 minutes. No problem.
So, whoever has joined, we are doing webinars every week or fortnight for now under the leadership of Dr. Archana Vasir, our presidential candidate for this year. So, whoever we have joined in this webinar, I would be sending links to all of you. Please don't get bored of it and try to join every time because we're doing it like every weekly, ma'am, right? From now, weekly we are doing.
Yeah, but I mean under different this thing like focus
Yes.
series, then we have inspire series, and we have Shrinkala, and then different things. But yeah, we are bringing up every time different topics and very
I'm
interesting.
Dr. Purnima is there. Good evening, ma'am.
Good evening,
Hi Purnima, good evening.
Hi.
How can we start without you, Purnima?
No problem. You all are doing such wonderful work. You don't need me. I just love to come and see what you all are doing.
Oh, so nice of you. I think, Rupali, could you connect with Dr. Sheila or?
Sheila ma'am is not picking up the phone. Maybe she's busy. I don't know. Tried calling.
She must be managing some PPH somewhere. She's the PPH lady, so she must be managing. So I think we can start. I'll meanwhile, when Dr. Sheila comes, we'll just read her CV and we'll introduce and we can start off. Let's begin. Sudeep ji se bol dijiye countdown and we start.
Sudeep sir. Very good evening to all the dignitaries. And we have once again met today for the focus series under the able guidance of Dr. Purnima Satoskar, madam, who is always forthcoming and always, helping us out whenever required. And we have this brainchild of none other than Dr. Archana Baser, ma'am, who we all know to be a very, very dynamic doctor. And the more I know her every month, the more I'm falling in love with her and want to be like her. So once again, this is our monthly series, focus series under the this banner of RCOG West Zone. And today we are coming up with a very important theme, which is decoding gynecological imaging. So we'll be taking you through a very common problem which are faced by almost all the gynac patients who are walking in our OPD, and how to interpret the reports, how to go about the investigations. We have a wonderful talk by Dr. Archana Baser, ma'am, also, and then followed by an equally important and very nice panel discussion by Dr. Girja Wagh, ma'am. So over to Dr. Manila, ma'am.
Yeah, good evening, everyone. It gives me immense pleasure to introduce our distinguished speaker, and as said by Dr. Rupali, the brain master of this webinar, Dr. Archana Baser, a renowned obstetrician and gynecologist and director at Akash Hospital, Indore. Dr. Basir holds an impressive list of qualification, including FRCOG, and has made remarkable contributions to women's health and medical education. We could see her as a faculty in almost all of the conferences everywhere. She has served in numerous leadership roles, including Vice President of FOXI in 2020. She was Organizing Secretary of AICOG 2021 Indore. She is currently Chairperson of ISAR MP Chapter, and she has also been an active fellow representative for AICC RCOG West Zone and Joint Secretary of ISPAT. In past, Dr. Basir has held key positions such as chairperson of Foxy Imaging Science Committee, and we have seen many workshops under her leadership. Organizing secretary of ESAR 2016 when I was just new to Indore, and managing committee member of ESAR, AIGE, and ICOG. She has also contributed internationally as imaging science chair for CEFOG and as a member of AOFOG. Her dedication, leadership, and academic excellence has earned her wide respect and recognition, and she continued to inspire all of us. We are truly honored to have Dr. Archana Basir, a Guinness World Record holder and Foxy presidential candidate for 2026, with us today. And I'm very thankful to Dr. Basir for giving me this opportunity for being convener of this focus webinar series today, along with Dr. Rupali, who has done her job with excellence in managing the whole flow of event. So let's welcome Dr. Basir, ma'am. Over to you.
Thank you, Manila, for your kind introduction. And what I can say, like you are the pillars of whatever we are doing, you and Rupali, for this focus series. And I'm truly indebted to Dr. Purnima for giving us this platform of AICC RCOG based zone to do webinars the way we want to do it. And I welcome all the dignitaries who have joined in this webinar. And this is a very interesting topic and very important topic which we have taken, because what I see when I'm traveling, as Manila has said, that I'm traveling to different parts of the country during my campaign and even before also, obstetric topics are covered. I mean, obstetric is important, but not many times gynec ultrasound is not that well covered in the even in the conferences, even in the workshops, or even when you're talking about the online things. So it is important because we as an obstetrician and gynecologist are dealing with both the problems, obstetrics as well as gynec, while the gynec starts earlier and ends even after the reproductive life. So I think exposure to the gynec problem and to the gynec sonography and learning about it has to be really given an importance in our training curriculum and in our webinars and workshops and scientific programs. So for that, we have discussed amongst our core group, and we decided that we keep this topic, and we keep a topic on adnexal masses and a panel on, first it was like challenging gynecological challenges in gynecology. Manila came up with decoding gynec ultrasound. I think that sounded very interesting, and I'm sure Dr. Girija War and her team of panelists are really going to do a wonderful thing in that panel. And to really grace the occasion of this webinar, we have as our guest of honor and Dr. Shailesh Kore. He is president-elect of MOGS. And Dr. Shailesh Kore, I have known him for many years when I was working in Mumbai at KM Hospital and Rajawadi Hospital as well. So he's a professor and unit chief, TN Medical College and BYL Nair Hospital. He has 32 years of teaching experience and organizational position. As I said, he's president-elect MOGS and number of publication. And he has special awards and recognition, more than 30 awards, prizes, Foxy Korean Awards, Pramila Bhatia Young Scientist Award, Foxy USV Fetal Medicine Fellowship, and Har Gobind Medical Fellowship. And he has been very kind of him to accept to come to this webinar and spare time to give his inputs on the topic we have selected and on the webinars. And I would like Dr. Shailesh Kore to on the dais to talk to us. Then I'll call our own Dr. Purnima. Over to you, Dr. Shailesh.
Thank you, madam, for a kind introduction, and good evening, everybody. It is actually my really a privilege and honor to be invited as a chief guest for this AICC RCOG West Zone Focus webinar series under leadership of Dr. Archana and Dr. Purnima, and on the topic of decoding gynecological imaging. One thing which was affected during COVID, I think, was education, mainly the medical education. And I think, but as Napoleon Hill said, that every adversity, there is a seed of equal opportunity or a greater opportunity. And then what started as a depressing period in COVID pandemic turned out to be a boon for education with the use of digital platform. And with this Zoom or a digital platform, we are able to reach to more and more people. And we can see on Foxy or MOGAs or various other organizations, almost every day there is been a educational webinar. So people are really blessed to have so many the teaching material at their disposal, and it's really a very good. So I'm happy to be a chief guest for this virtual focus series on decoding gynecological imaging. We have, as Madam said, a very excellent program in form of a lecture, which is will be given by Madam herself, Dr. Archana, and then the panel discussion, which will be moderated by my friend Dr. Girija. And we have a very renowned panelist for this panel discussion. I think, as Madam said, I was associated with Dr. Archana for a long time, and we were chairperson of Foxy committee. Madam was a chairperson of, I think, the Imaging Science Committee, and I was a chairperson of a Fetal Medicine Committee on the during the same period. And because the imaging is an integral part of fetal medicine, I think we used to have a lot of interaction. I remember Madam contributed a chapter on imaging when I edited a book on multiple pregnancy during my tenure, and it was very well appreciated. So I really thank Dr. Archana Basar, uh, and I'm really I want to congratulate her for her excellent work. And again, I'm wishing her all the success in all her future endeavors, and including Foxy presidential election, which is will be contesting next year. Dr. Purnima, as all of us know, is at present in AICC, and she will be taking as a chair, and me as a MOGS president next year, and Purnima as a AICC chair will be hosting AICC RCOG conference in Mumbai in October 2026, and I am just requesting everybody to attend that conference in a large number and make it a grand success. And before I end, we have Dr. Sheila Mane, who's a PPH lady, and I think she is busy with, must be on with some other, and Dr. Girija, Dr. Kuldeep, who will be really imparting a lot of knowledge. And I'm just looking forward for this webinar. And I know that at the end of this webinar, everybody, those who are attending this, will be much wiser as far as the gynec imaging is concerned. And before I end, I think I again thank Dr. Archana Bese, Dr. Purnima Satoskar, and Dr. Rupali and Dr. Manila for inviting me as a chief guest. And I wish this program and this series as a whole a big success. Thank you very much, and thank all the best for everybody.
Thank you. Thank you, sir.
Thank you, Dr. Shailesh, for your nice inputs and your gracious presence. So please do stay with us for some time. And now I would like to invite our AICC RCOG West Zone Chair, Dr. Purnima Satoskar, to give her inputs and her remarks on this webinar, because she is a fetal medicine person, we know, and she does like but when we are talking about the gynec ultrasound as well, I think they go hand in hand. So gynec ultrasound, if you do good gynec ultrasound, you get pregnancy and then you get fetal medicine. So I think you have to know the gynec ultrasound also well. She is professor and unit head of St. GS Medical College, and she is head fetal medicine fellowship, MUHS Wadia Hospital, and she's consultant Jaslok Hospital and Research.
Thank you, Archana.
And so yeah, Purnima, over to you.
Yeah. So let me just congratulate you and the conveners Manila and Rupali for this selection of a very good topic, because we all do obstetric ultrasound, but we don't systematically do gynec ultrasound. And in gynec ultrasound, it's becoming now more systematic, more objective, and there are scores. It is not just a visual impression, I think this is an endometriotic cyst, but there are scores like ORADs, ADNEX, IOTA, and I'm sure our experts will be throwing some light on this. And soon, I think we will have AI also, which will ensure the, quality, excellence, and advanced analysis, trying to differentiate between benign and malignant. So we are really looking forward to this topic. And I welcome all our experts who have come here to share their knowledge today. And I hope it really goes well. Thank you.
So much, Purnima, for being here and encouraging us to carry on and continue with whatever we are doing. So thank you very much. So over to conveners for further taking the scientific program ahead.
So, Dr. Rupali, shall
Yes.
we now
Yes.
call chairpersons? Yeah.
We call upon Dr. Geeta Balsarkar, Madam. Madam, I've been associated with Madam right from my post-graduation days, where she was our lecturer in Vadia. She's a very dynamic person, an amazing wealth of knowledge Madam has. She is the editor emeritus of Journal of OBGYN India. She's the secretary of MOGS, President Association of Medical Women in India, Mumbai branch, president of Menopause Society, Mumbai branch. She's the chairperson of Young Talent Committee, FOXY, recipient for the prestigious Hargobind Foundation for the Study of Fetal Medicine at St. George's Hospital, London. And currently she's a professor, St. GS Medical College and Norosji Vadia Maternity Hospital. She has also undergone training for the PPIUCD program and is also the faculty member of many training programs as well. Madam, we welcome you and we are waiting to get a real expert opinion after the panel discussion as well. We would really want your inputs on this because you have a vast experience in Vadia Hospital, which caters to thousands and lakhs of patients. So thank you, Madam, for accepting the invite and being the chairperson today.
Thank you.
So our next chairperson is Dr. Anusha Devala. I'm sorry if I am not pronouncing you well, Dr. Anusha. You can correct me. So she is faculty at AIIMS Hyderabad. She holds MRCOG degree with over 13 years of experience as an obstetrician gynecologist and laparoscopic surgeon. Dr. Anusha has received multiple awards, including the Best Oral Presentation at AICC RCOG 2025 and Young Research Award as well. She has authored over 15 textbooks chapter, including the Shaw's Textbook of Gynecology, which is quite prestigious, and I'm thrilled to know that, and published more than 40 research papers. So we warmly welcome Dr. Anusha for today's session, and we're looking forward for your expert opinion after the talk. Thank you for accepting the invite, Dr. Anusha.
Thank you so much, ma'am.
Right. So may I be allowed to share my...
So now with that, we'll start with our first session with Dr. Archana Basir's talk.
So is it visible? Yeah.
Yes, ma'am, it is visible.
Okay. So good evening once again. And we begin with a topic, ultrasound in adnexal masses. And respected chairpersons, Dr. Geeta Balasarkar, the 1 minute share lady, who everybody I think is following her 1 minute share, which are very, very good. And Dr. Anusha, I just knew you as like, in Chennai we met, but today when I seeing your illustrious CV, I think lot you have done. So I'm really feeling that yes, we have the chairpersons who are really going to give good inputs on my talk. So when I was preparing this talk, I was thinking why adnexal masses in infertility or in the ultrasound, why it is important. So why I said that why in gynecology you should know about the adnexal masses, because most of the gynecologists nowadays, like infertility practice is on boom. Majority of the youngsters or many gynecologists are just doing super specialized practice. I just want to practice infertility, I want to practice laparoscopy or like that. And many of us are doing our own ultrasound. And as an infertility specialist or as a gynecologist, you pick up adnexal masses on ultrasound. And most of us are doing especially the infertility specialists are doing their own ultrasound. And to optimize outcome of fertility treatment, adnexal masses must be addressed. So what is the concern? Whenever you report an adnexal mass on the ultrasound, it may be symptomatic, it may be asymptomatic, and it is one of the most commonly encountered entity in gynecological practice, and causes considerable anxiety. The anxiety is the fear of malignancy. If you tell patient that you have a cyst or you have a mass, they will, have so much of fear. So let's look at the incidence of adnexal masses. So adnexal masses are common in women of reproductive age, with reported incidence ranging from 0.17% to 5.9% in asymptomatic individuals and 7.1% to 12% in symptomatic ones. And the most frequent masses in this age group are benign functional cysts, such as corpus luteum cyst or sometimes the leiomyomata. And while most are benign, the risk of malignancy increases with the age, though it remains low in young and asymptomatic women. Now, imaging in adnexal masses, that's the topic. So what is the role of ultrasound? Ultrasound helps in characterization of the ovarian masses. Ultrasound is often the first line method of choice, especially for distinguishing cystic from complex cystic solid and solid lesions. There is role of CT and MRI as well. They are useful when there is a staging is needed for proven malignant lesions, and especially if there is a complex lesion, you do need MRI. And by using MRI as an adjunct to sonography, a delay in the treatment of potential malignant ovarian lesion is prevented. Now, this is how I approach, and this is the systematic approach to adnexal mass. Step one, whenever you are scanning, you see an adnexal mass, you have to make sure that it's an ovarian or it's a non-ovarian. Then you have to see ultrasound pattern recognition, whether it's a simple cyst, it's a hemorrhagic cyst, it is endometrioma, it is a mature cystic teratoma, or it is any other cyst, possibly malignant cyst. And if it is like a simple cyst, then you can ignore it. Or if follow up with ultrasound or evaluation with MR or surgery if there is a suspected complex lesion. If a cystic adnexal mass is present and you suspect an ovarian origin, the first thing is to try and identify the ovaries. And if the gonadal vessels lead to the lesion with no separately identifiable normal ovaries, then most likely you are dealing with an ovarian lesion. If both ovaries are separately identifiable from the lesion, you are dealing with a non-ovarian cystic lesion or a lesion that mimics a cystic mass. And the next step would be to check if there is a uni or bilateral disease and to look for any solid components that may indicate malignancy. Also look for secondary findings like ascites, enlarged lymph nodes, and peritoneal deposits. So this is and ovarian, the adnexal masses or ovarian cysts can be from as young as 11 years to maybe 90 years of age. You can have that wider age range. And the transabdominal view of pelvis in a young woman where you cannot do a transvaginal scan, it does puts the challenges to you because ovaries cannot be delineated very well, because there are sometimes in a younger girl who comes to you with a little adnexal mass, and you may not be able to delineate it very well. So that will be a little challenge. So what you have to do is, like, you have to see for the normal position of ovary in relation to the iliac vessels, like how you see here. This is a normal position of ovary just above the gonadal vessel. That's what you will see. And this is the measurement of ovary and the ovarian volume. You have to measure it in the three directions. So ovarian length, width, and height, and then you can calculate the volume of the ovary. Now the different positions of the ovary, these are like a kissing ovaries. They are in the pouch of Douglas behind the uterus. So they are like adjacent to each other. They are prolapsed, and then this is a PCO ovary, which is again prolapsed in the pouch of Douglas. So now, what are the differential diagnoses of benign ovarian lesions? There can be a corpus luteum cyst, there can be follicular cyst, there can be luteoma of pregnancy, mature teratoma, ovarian torsion, polycystic ovaries, serous and mucinous cyst adenoma, theca lutein cyst, or endometrioma. Malignant ovarian tumors can be borderline tumors, epithelial carcinoma, ovarian germ cell tumor, ovarian sarcoma, sex cord, or stromal tumor. Benign non-ovarian can be hydrosalpinx, which is again a common finding, pseudoperitoneal cyst, ectopic pregnancies, para-ovarian cyst, TO abscess, and then you have malignant non-ovarian, that is endometrial carcinoma and fallopian tube carcinoma. There can be non-gynecological benign lesions also, like appendicular abscess, pelvic kidneys, and bladder diverticulum. Let's just focus on now the ovarian cyst. Ultrasound is gold standard diagnostic modality. An ovarian cyst can be seen in all ages of women, as I said, from 2 years to 90 years, and also in 18% of postmenopausal women. And cysts in ovary are common but not reported appropriately. This generates a lot of anxiety because whenever, as a gynec ultrasonologist, you are reporting an ovarian cyst, please follow the protocol that yes, this is unilateral, bilateral, as I said, and whether it's a clear looking cyst, what are the content, what is the vascularity, everything has to be reported, so that even if the report is read by other colleague or other person, they know that what we are on the same page and we are talking the same language. That is the purpose of learning the gynecological ultrasound, and reporting is very, very important. So what are the common adnexal masses in reproductive age group? Always think of the common things then rather than uncommon. Simple cysts are the most common. Then hemorrhagic ovarian cyst, endometriosis, ectopic ovarian hyperstimulation syndrome, though it is becoming less, but it has to be kept in mind because now because of the ART, there is a risk of OHSS and para-ovarian cyst as well. So this is a follicular cyst of the ovary. Note the rim of the ovarian tissue at the periphery. Very simple follicular cyst of the ovary, which is common occurrence when patient is going through ovulation induction, and maybe even without induction, but more common when ovulogens are given. This is again a simple follicular cyst. See the rims, thin rims, very little vascularity, very clear content, round. So what you can do when there is a simple follicular cyst of the ovary, you can just follow it up by a sonography on the different day of the cycle, so, especially the post-menstrual time. So then this follicular cyst may spontaneously resolve. So that is very important. And this is a hemorrhagic cyst of ovary. What you see here in this cyst is there are a cobweb kind of appearances because of the clots, the blood clots there. So there's a different this kind of picture you will find. So it does look complex. It does look that there can be a problem, but just put the color. And a special thing when we talk about the ovarian cyst, must take the menstrual history well, that when was the last menstrual period. You are scanning it in the follicular phase of the cycle, luteal phase of the cycle, or patient has missed a period, or the patient is taking any fertility treatment. So these are the very important thing which one should ask. Now you have in this picture what you see, that ovary is seen separately, and then this is an adnexal mass. So this is a tubal ectopic, which is again an adnexal mass. This is again a picture of adnexal, this ectopic pregnancy. You can see the gestational sac seen separate from the ovary. This is ovary and this is a gestational sac seen. So that is again a differential diagnosis of adnexal mass. And other things which we have to see in ovarian cyst is like endometriotic cyst. This is an endometriotic cyst. What happens in the endometriosis, the ovaries are invariably stuck behind the uterus, and this is a ground glass kind of appearance, and there are adhesions in the POD which can be seen by the sliding sign. And this is again another kind of a cyst reported in ovary, that is PCOD. And this is really becoming very common. Women will come, or the young women will come to you with the diagnosis of PCO. You don't have to give the diagnosis. They'll come, doctor, I am being diagnosed with PCO. And this polycystic ovary, means multiple cysts in the ovary, really causes lot of anxiety, and it requires a lot of counseling. And this is a very common finding of a PCO. Now, what we have to do, I'm sorry about this repetition. So this is again this is a picture of a hydrosalpinx. This is the ovary, which you can see clearly. This is an ovary, and this is a cystic structure, that is an hydrosalpinx here. What happens in the hydrosalpinx? You just will find a incomplete septi. So that is the classical feature of the hydrosalpinx. Ovary you can see here, this is the vessel, this is the ovary, and this is the right adnexa which is seen. So that's a hydrosalpinx adnexal mass. And pattern recognition, as we talked before, simple cyst, anechoic, posterior acoustic enhancement, unilocular, thin walls, and smooth, no solid or well vascularized component. This is again a follicular cyst. Now this is again a hemorrhagic cyst. I brought again this picture just to see that how this the fibrin deposits, and there is a different fluid levels which can be seen here. So cystic mass with solid appearing areas without Doppler blood flow and concave margins consistent with blood clots. So that is to be that has to be really identified. This is a picture of a dermoid on day third of a period in a very young woman. She was I think 18-year-old, presented with pain in abdomen, and what you see here is a little bit of collection, and this is the dermoid cyst. And then look at the endometrioma. Endometriomas are homogeneous and hypoechoic mass, diffuse low level echos, ground glass appearance, no blood flow on Doppler, no enhancing nodules or solid mass. 30% will have echogenic mass in the cyst. So this is a very clear, what you see is a echogenic mass here, and this is a ground glass appearance. This is a picture of mature cystic teratoma, hypoechoic mass with hyperechoic nodule, Rokitansky or dermoid plug. 90% of the dermoids are unilocular, 30% have calcification, tuft of hair, hyperechoic lines, fat fluid levels may be seen. So this is a dermoid. Then this is a dermoid cyst in an unmarried young girl of 15-year. Note the hyperechoic cystic structure here. She presented with pain, and the treatment for dermoid, as we know, is laparoscopic removal of the dermoid cyst. Then what I think we have seen the hydrosalpinx. This is a picture of the laparoscopic picture of the hydrosalpinx. What this is the picture of the same thing on the sonography, and what you see, it is stuck here, hydrosalpinx, and there are adhesions on the laparoscopy. This is a post hysterectomy ovarian cyst, because this is also called a pseudoperitoneal cyst. Of this 37-year-old woman had a hysterectomy done, and she had naturally the ovaries were left inside too because of her age, and what she got was the ovarian cyst. And then you cannot really clearly identify the ovarian structures, but we did a laparoscopy and removed all the here, and this is cyst. And this is, as I said, OHSS, ovarian hyperstimulation syndrome in the IVF. What you see are the very enlarged ovaries with multiple follicles, and these follicles have got the clear fluid, and what you can see is a little fluid in the peritoneal cavity as well. And this she was pregnant with a twin pregnancy and had a tough time managing her with the OHSS and twin pregnancy. Then one more thing what you have to remember is adnexal mass, and you can identify it on ultrasound, are the ovarian cyst excidents, that is the torsion of the ovary. Torsion ovary will also present as an adnexal mass. So what are the grayscale ultrasound features of ovarian torsion? Unilateral enlarged ovary, more than 4 centimeters, string of pearls appearance, coexistent mass within the twisted ovary, free fluid in the pelvis, twisted vascular pedicle, and usually located in midline or superior to fundus. And this is called a whirlpool sign. At color Doppler sonography of the twisted vascular pedicle, visualization of circular or coiled vessel in the whirlpool sign is seen. Now, in other, as I said, the ovarian cyst can happen at any age in the women. This is a young girl, which is premenarche, and she had an adnexal torsion in at 12 years of age, and 3 weeks of history of intermittent abdominal pain, which was thought to be due to constipation. And we did a grayscale ultrasound image which shows an enlarged ovary with stromal edema, and duplex ultrasound image shows peripheral arterial blood flow and absent, greatly decreased central blood flow, and its surgery ovaries appear necrotic. So this is a pre-pubertal uterus. If you see, this is just lying over the ovarian mass, and if you see the blood supply here, there's no blood supply inside the ovary, it's only at the periphery. We could not salvage her ovary. That was a very traumatic for us as well as not salvage, as there was a completely blue ovary with lot of fluid in the peritoneal cavity. So when we could not get the color of the ovary back. So this is torsion ovary. Again, on the grayscale ultrasound, it will appear like this on the top of the uterus. Remember, whenever you are putting your ultrasound probe in a young girl and you see the clear space or the cystic space above the uterus, apart from the bladder full, think of that you are dealing with an ovarian cyst or maybe more or less the torsion, because whenever the ovary will have torsion, it will come on the top of the uterus. So that's a torsion ovary. This is a very rare case where there is a torsion of hydrosalpinx. One of our 48 years old women presented with severe pain in lower abdomen and admitted for conservative management at some hospital. We did a ultrasound and found a 8 centimeter cystic structure. Both ovaries could be visualized and history of tubal ligation was there. Look at the laparoscopic picture. This is a torsion of the hydrosalpinx. We did a TA, total abdominal hysterectomy, and salpingo-oophorectomy. This is a serous cyst adenoma will look like. Serous cyst adenoma are benign lesions. They are commonly serous adenoma are large, unilocular, thin-walled cystic lesion that may have thin septation or papillary projection. So you can see this is a serous cyst adenoma. Again, a serous cyst adenoma. This is a large serous cyst adenoma with multiple intervening septi and clear fluid-filled cyst with minimal vascularity. This is a mucinous cyst adenoma. And then again, mucinous cyst adenoma with thick intervening spaces is seen. So you can really differentiate between the different cystic lesions or adnexal masses by a good high resolution ultrasound and knowing that what are the features or of what particular cyst. Now, features of malignant versus benign. Malignant are irregular solid tumor, ascites, 4 papillary projections, irregular multilocular cyst, and very strong flow color on the score 4. And these are the features B1, B2, B3, B4. As Dr. Purnima was saying that we have to really have a classification when you're talking that it's a B1 lesion, B2. So same thing like that. And possible malignancy, you can pick up the possible malignancy also when there is a ascites, there is a septate, and there is a color flow. This is a very, I will end with this case, very interesting case of my very favorite patient. She was I think 19-year-old. When she came to me with a torsion ovary, at 6 p.m. in the evening, I did detort her ovary, did excision because to reduce the volume, didn't cut the ovary. But when we sent the biopsy material for the biopsy, it said that it's a borderline tumor. We did a lot of counseling. She was at the age of 18. She was married. We did that over because it's a surface tumor. It can it is a potential problem can happen. Conserve the ovum and all, but that was not considered as a possibility. Then she presented to me a year later with this. She did come back for follow up, and we saw that at that time ovaries were looking okay. And when we scanned her, look at this picture that these are this ovary has multiple follicular kind of things. And what you see here are the nodules, which are called as the mural nodules or the solid lesions in the ovary. And then this is again, these are the nodules. So she got operated again for removal of the nodules and debulking. Eventually, this young girl ended up with total abdominal hysterectomy and BSO at age of 22, which is unfortunate. But as we know that borderline tumors of the ovaries can very quickly progress to malignancy, and she kept getting it again and again. So that was the only solution. And these are the certain pictures of the malignant tumors that there are how the vascularity is there in the malignant adnexal masses. So this is again the nodule with the blood flow there. And now how do you manage? Appropriate management of patient with an ovarian cyst depends on presence of symptoms, likelihood of torsion or rupture, pregnancy. So key point is it is critical for clinician to know the different types of ovarian cysts, to apply and be able to interpret appropriate investigations, to be aware of the treatment options available, and to understand when referral to a gynec oncologist is indicated. And just a take home message is ovarian cyst, also known as ovarian masses or adnexal masses, are frequently found incidentally in asymptomatic women, and ovarian cysts are sometimes found in the course of evaluating women for pelvic pain, Though the cyst may or may not be cause of the pain, for the vast majority of women, ovarian cysts are not precancerous lesion and do not increase the risk of developing ovarian cancer later in life. Removal of benign cysts does not decrease future mortality from ovarian cancer. So please take care not to remove the benign cyst. If patient is asymptomatic, leave, do not touch the ovaries unless and until it is very, very imperative for you to take it. And we have this adnexal masses. I mean, we have published this book, Obstetrics and Gynec Ultrasound for Beginners, where this all is being covered. And I would like to thank everyone for patient listening. And I would like to end with that adnexal masses are common. What we have to do is a very good counseling, not to increase the fear amongst our patients, but to do a proper counseling and make them understand that yes, there is a problem. I know what happens in our practice. Whenever there is a cyst or a mass or something is reported, patient wants an immediate answer, like a magic wand, that yes, I want an answer and I want a treatment. But sometimes we have to do a counseling that, well, we need to wait and we need to follow it up in the next cycle, or we have to give them a roadmap that how the follow-up of this particular cyst or this particular lesion will be done. So there are two kinds of lesions. One can be dealt medically and by patients, and one which will require surgery. So that's what is the aim of doing. And today in the modern time, when we have good technology and good machines, no women with adnexal mass should go home without a real close to diagnosis of her pathology by ultrasound. So we all should become good gynec. We should interpret gynec's sonography reports and request a radiologist colleague to write it in the detail about the adnexal mass if they have found one. So thank you very much for patience listening.
Thank you, Dr. Archana ma'am. Sorry to interrupt here. Dr. Sheila Mane ma'am has just joined. So we would like to welcome her first and then take comments from the chairperson. Is that okay, ma'am?
Yeah, of course, Dr. Sheila Mane. It's my fault that I wrote the wrong date, I think.
No, no. Actually, I only missed it. Now, when you called, I realized that because I was out of station yesterday. So, very nice session. I think very nice conceptualized and really congratulations, Archana, for coming out with that book on adnexal masses. I think it will be really a very important a message through I think through those chapters because all of us, as you rightly pointed out, that the patient becomes really panic, and everybody one smallest thing also. So it is good to know that all the benign cysts, first of all, we have to do the counseling and try to convince them. I think that's a very good point. And as you said, and now we know the technology has really improved so much that we can definitely differentiate between benign and malignant. So I congratulate you for coming out with this focus series of RCOG. And I know that the next is going to be again a panel discussion, and which will be definitely very fruitful for all the delegates, those who are attending. And I would like to congratulate all of you, Dharwadkar, Anusha, as well as Archana and Madam Satoskar. And thank you for giving me the opportunity to be here as a
Let me
guest of
introduce
honor.
and let me welcome you, Dr. Sheila Mane. Thank you so much for your inputs. But let me introduce everybody. Dr. Sheila Mane, she is ICOG chairperson elect, and she is very famously known as a PPH lady of Foxy, because I have seen her traveling all around with that model and where she will teach everyone the PPH. So see, I've known her since those days. She has been Vice President Foxy 2014 and Chairperson of Safe Motherhood Committee. And she's a great friend, and she is a very down-to-earth person and very approachable, and just a phone call
Thank you, thank
kind
you.
of a person.
Thank you, Archana.
And looking forward for a good ICOG sessions during your tenure. So thank you very much for joining.
Thank you for those kind words. Thank you.
Thank you, Sheila ma'am, for joining and giving your words of wisdom to all of us. I would request chairperson to give your comments and opinion after the talk of Dr. Archana Vasir, Dr. Anusha, Dr. Geeta.
I congratulate Madam for giving such a comprehensive, the talk on a very comprehensive topic and nicely giving all the illustrations. So here we have been, I want to just share my experience how we are having patients in Hyderabad. So many of patients who are having these adnexal masses, they get referred to us from all the age groups, and many of the times I have seen that patients are having a report showing and we request our radiologist senior here. So that comes out to be a simple hemorrhagic ovarian cyst. So it's very important to differentiate endometriosis cyst and from a hemorrhagic ovarian cyst. The findings are very typical of having a reticular pattern, and as Madam has nicely shown the ground glass appearance of endometriosis. So, so this differentiation also I think is very important and is a take-home message for the delegates as well. So apart from that, Madam has covered everything very nicely, and it was a treat to the eyes.
Thank you, Dr.
Thank you, Dr. Archana. It was a very, very informative lecture. And I think as gynecologists, we should always think of adnexal mass in the rarest and in the most difficult situations like postpartum period, or there are a lot of times when we really miss doing an ultrasound, or for somehow we don't do an ultrasound, but these are the exact situations where we should keep our antenna up that there could be a possibility of an adnexal mass. And secondly, here I would wish to remember my teacher, Dr. Vivek Patkar here, who used to say that a morsel of ovary is better than a prescription pad full of estrogens. So wherever possible, we should always conserve the ovary. We should conserve the ovary, but of course, we have to rule out malignancy in all the cases. And as far as possible, sometimes even when there is a partial torsion or wherever we can conserve, sometimes the ovary looks very edematous and very large and edematous, but somehow after some time they settle down. So wherever possible, we should conserve the ovary, and because it goes a long way, the patient's lifespan is increased, and therefore we should try and conserve the ovary as much as possible when we are dealing with this ovarian cyst. Thank you very much.
Thank you, Dr. Geeta. I think this is a very important point that we have to conserve the ovary. So that's why it's very important that adnexal masses are addressed properly by imaging, so that the fear is less and the person who is operating knows that they are not leaving behind the malignancy, they are just leaving a benign problem.
Thank you.
Thank you.
Thank you, Dr. Geeta ma'am and Dr. Anusha, for giving your giving and sharing your valuable insights today on a very important topic of evaluation of adnexal masses by ultrasound. With that, we move on to our next session of panel discussion. For that, I would like and request Dr. Archana Baser ma'am to introduce the moderator of the panel, Dr. Girja Wag ma'am. So Dr. Girja Wag ma'am has already joined. Welcome you, ma'am. Over to you, Dr. Basir.
Dr. Girija Wag, I have known her as a person who is really very well read and a very great academician and very straightforward. So she's professor and head of Department of Obstetrics and Gynecology of BUDTU MC Pune. That you have to expand it for me, Girija. Director Primrose Wellness and Care. And she has a professional highlights. If you see, she is a veteran gynecologist and medical consultant, expertise in patient management, research, and medical education of 34 years. And she has led Foxy as a former VP Foxy, chair of Medical Disorder in Pregnancy Committee, and national mentor of Laksha and NPO QCN. I think she has a lot of contribution as an academician and as research contributor, structuring medical workshops, refining research topics, and she's a healthcare innovator. She has a lot of awards. Anandibai Joshi Award for Excellence in Medical Services. And for all of you, Anandibai Joshi was, I think, the first female doctor from our country, faculty, OGHS International Expert General Coordinator and Vice President India Chapter of Gestosis. And the most beautiful thing about Girija is she can give moderate sessions or give a talk on any topic in obs and gynae, not only just focus on gestosis. When I said, Girija, we need to take a panel on gynec ultrasound, she never even asked me the second question. Oh yes, I'll do it. So she's again a very, very person who you can bank upon if you for any topic. So over to you, Girija, to moderate this very interesting session where you have a good, panelists who are really going to contribute to your panels and questions, and everybody's looking forward for your moderation.
Thank you so much. Is that going to be introduction of the panelists as well?
Yes, ma'am.
Yeah, I think we shall do that formally, Rupali.
Yes, ma'am. We'll just quickly introduce our panelists. We are very lucky to have all eminent panelists with us today. Dr. Jayashree Sharma, she is an executive committee member. She has translated MBBS curriculum also into Tamil for the government of Tamil Nadu. She has received various awards and appreciations during the COVID periods. She's a medical writer, motivational speaker, gives a lot of interviews in Tamil news, written articles in many leading magazines, and she has a very active social media with more than 70K followers. Next, we have is Dr. Manjir Mitra. She's a very good friend all the way from Kolkata. She's a managing committee member of the Bengal Obstetric Gynec Society, member of Foxy Family Welfare Committee, recipient of the Youth Excellence Award, and she's also an MRCOG Part 2 and 3 mentor with a med exam expert. Our next panelist is Dr. Poshali Sanyal. Madam is affiliated to Woodland Hospital, Bellevue RSV Hospital from Kolkata, managing committee member of BOGS, member representative of IRC India East Zone, clinical secretary of ISOPAP Kolkata, and she has to her credit many papers which are published in national and international journals, and she's written many chapters in various books. Next, we have is Dr. Suyesha Khanjiao. She is a diploma in advanced endoscopy. She's got a fellowship in reproductive medicine. She's also got the President Appreciation Award, Dr. APJ Abdul Kalam Health Award. She has the Times of India Award for the best IVF specialist in North India. So welcome, Dr. Suyesha, and Dr. Manila. You can introduce the other panelists as well.
Thank you, Dr. Rupali. Next, we have Dr. Mansi Vaish. She is Secretary of Dehradun OBGYN Society, past Joint Secretary of GODS 2019-21. She has done a senior residency from Delhi, trained in advanced laparoscopic and hysteroscopic surgery, trained in reproductive medicine, got various awards, and has won various prizes in national conferences. So we are glad to have you, Dr. Mansi. Next, we have Dr. Kuldeep Singh, a very well-known teacher and a very great radiologist we know. He has been masters in the field of ultrasound, which he is so passionate about. He practices ultrasound in New Delhi, and we know him through his skills, through his webinars, and so many sessions we heard him across. He has done more than 800 talks in national and international platform, invited to various countries on his talks, has received 4 awards and 3 gold medals in the field of ultrasound. He's authored 16 books. Wow. So his books has been translated in various languages. He was awarded the Imaging Science Award in AICOG Delhi. He's successfully running Sono School, which is so popular, which organizes various training program in ultrasound in OBGYN and infertility. He delivered the prestigious Dr. V.N. Shirodkar oration in Sholapur. Welcome you, sir. Next, we have Lieutenant Colonel Dr. Sumitra Gajraj, and she is a Lieutenant Colonel in the Indian Army and a specialist gynecologist with 16 years of leadership in medical, operational, and administrative domain across India and abroad, known for her integrity, adaptability, and excellence, recognized by the Chief of Army Staff Comedian. So welcome you, Dr. Sumitra. Next, we have Dr. Gauri Meena, a very renowned doctor from Chennai, and she is a recipient of many awards during her MBBS, in her post-graduation, recipient of Pfizer Award, recipient of ICMR Studentship Awards, recipient of EL Murlikar Traveling Fellowship Award. And I can see that there are so many awards under her name. And with that, we would be truly honored to have all of such accomplished panelists with us today. And I'm handing over now session to our moderated, respected Professor Dr. Girja Wag, ma'am. Over to you, ma'am.
Okay, thank you so much. I'll just share my screen. So at the outset, I would like to thank Dr. Archana Basair for such a wonderful introduction, and also to Rupali for coordinating this entire thing. It's definitely a task to speak on dilemmas in gynecological imaging, something very different, because all as gynecologists we are all about therapy, prevention, and then doing surgeries. And I can see the eminent panel is full of such very astoundingly, remarkably achievers in the field of gynecology. Secondly, the long form of BVTD-UMC is Bharati Vidyapeeth deemed to be University Medical College, Pune. And I've been serving there for the last 35 years, and we are an NABH accredited hospital plus NAC accredited university, and which we are very proud of. In our third time, we have received A2+ grade. So, and we have wonderful alumni all across the country. So, and secondly, I'm sorry I have not mentioned Dr. Meena Gauri's name in my entire panel discussion, because somewhere when the message was posted in this particular group, her name was taken off and I didn't confirm. I'm sorry. But then if she's around, I'm definitely going, yes, Meena madam is there. So Meena, I'm going to ask you questions, which we have already posted, but I'm extremely apologetic that I didn't put your name, because there was some message in which your name was not mentioned. So I thought maybe you're not coming up, and that's the reason why your name is not there. So let's move on to this particular panel, which we have sort of planned in a way where we have already done the context setting, and then we'll have question answers, and I'm going to be really enjoying asking questions to such eminent panelists. And then we can have a consensus and maybe an audience question answer, because we should not lose this opportunity of asking questions to our expert panelists. So I'll just share an experience which I had recently. A 36-year-old unmarried woman came for presented with an abdominopelvic mass, and in an initial primary workup, she was suspected to have an ovarian mass. All the tumor markers under the sky that are possible were done for her, and then MRI also was done, which also said an ovarian mass. And then I said, let me examine you. Fortunately, she did allow me an transvaginal examination because she was socially active. And then I did a detailed evaluation and targeted scan after that in my own clinic. And it was actually a massive lateral intramural fibroid, FIGO type 6, which was degenerated. Now you can understand, friends, that this is such a turnover completely from an ovarian mass in a 36-year-old, where we are worrying whether it's going to be a cancer, to something which is completely benign. Of course, may compromise her fertility if she desires to get babies in the future. But then imaging and your clinical acumen both require to be looked into when we deal with it. And therefore, I want to congratulate Madam Archana Basair for having this wonderful brainstorming session where we can really talk and focus more on imaging, because this imaging can either kill you or make you as a gynecologist. And we have all had these experiences when the sonologist has written that there is a fibroid on the posterior surface. You go and try to do an surgery and you find out it was on the anterior surface, and therefore we have to be careful. So in the perpetual turf war between the radiologist and the gynecologist, the radiologist report often reads, findings are non-specific and require clinical correlationship, and the gynecologist translates, they have absolutely no idea what they are looking at, so now it's my problem. And yes, friends, it's going to be our problem. So the domains and dilemmas that we are going to discuss are going to be based on, we are starting from the inside of the uterus, endometrium, fibroids, masses. Then we go out a little, endometriosis, peritoneum, female genital tuberculosis, which we as Indians can never ignore, uterine AV malformations, and Mullerian anomalies and Asherman syndrome. So what is the evidence saying as far as endometrium, especially in the situation where there is a post-menopausal bleeding? We are all concerned, but I must also tell you, we should start getting concerned even in younger women. Because just about 3 days back, I have diagnosed a 26-year-old polycystic ovarian syndrome young woman, unmarried, with moderately differentiated carcinoma of the endometrium. So there, does not look at this endometrium only in the context of postmenopausal women, but that's a common problem and therefore we are discussing it here. So TVUS happens to be the first line ET less than or equal to 4 mm, the NPV negative predictive value more than 99% for cancer. Escalate to MRI for persistent bleeding, ET more than 4 mm or known cancer staging. And there can be discordance between hysteroscopy targeted biopsy. And therefore, my first question goes to Dr. Jayashree Sharma. When do you escalate from transvaginal ultrasound to MRI in postmenopausal bleeding?
So thank you very much for this opportunity. Particularly, the talk was by Dr. Archana was excellent, and I thank all the Manila and Rupali for organizing such a wonderful program, and Dr. Girija also. So this is a very practical question. So when I am in a clinic and such a patient is there and I am doing a TVS, and there is a history of postmenopausal bleeding, maybe the first bout of bleeding, I assume, and I am doing a TVS. So if the endometrium is first, as we were all discussing, the history and examination is very, very important. As Dr. Girja was explaining about that intramural fibroid, many a times I have seen the cervical fibroid or a fibroid polyp is completely missed by the radiologist. And even when we are doing also, we may miss, particularly if there is a fibroid polyp. So I always go with the history and then examination and then only the ultrasound. So if there is a postmenopausal bleeding, of course, the examination carries. So from where the bleeding is coming. So that's the first question. Then we have to make sure whether this bleeding is going to be from a benign cause or from a malignant cause. So these two we are going to differentiate, and for that only we need more investigations. So a postmenopausal bleeding can be just from a vulval abrasion or from a dry vagina or from the cervix. Maybe just the patient tried to have some coitus also. We have seen patients coming with some postmenopausal, particularly from the vaginal abrasions. So a complete examination and history is very, very important before going to the further investigations. And sometimes the transvaginal examination may be very difficult in a postmenopausal lady, particularly if she is after menopause, if it is maybe 6, 7 years, 8 years. We have seen the vagina is, we all know that the vagina is so narrow, and even the introitus is very difficult to do the transvaginal ultrasound. So in those cases, maybe without doing even transvaginal ultrasound, if I am not able to do, and I am doing only in a transabdominal ultrasound, and we know most of our people after 40, they just put on weight. Maybe we doctors are a little bit conscious. So the obesity is the main problem with ultrasound abdomen. It's very difficult to make out the endometrium particularly. So if there is a difficulty in making out the condition, whether there is a thickened endometrium or if there are any adnexal masses, definitely it is going to the next level of investigation, that is the MRI. Or the next one is, if I am not able to do transvaginal ultrasound, definitely I will need MRI. And if the endometrium is thickening is more than 4 millimeter, and if the patient is symptomatic, that is with the bleeding, definitely we have to make sure we are not missing anything. Because not only the endometrium, we always used to see first the uterus, then the adnexa. So we have to make sure whether there is any adnexal masses which is giving the estrogen. And another important thing is from the history, whether she is taking any HRT also. So when we know the history, we will know, we all know, what our mind knows, our eyes will see. And so with the history and then the how many bouts of this postmenopausal bleeding, as madam was telling, so these things very important before when we are proceeding to the MRI. So I think particularly when the imaging is, I am not very sure whether it is a benign or a malignant, or if it is going towards malignancy, definitely I will escalate to MRI.
Yes. So I think we should not have a hesitancy in trying to answer the question that, okay, my sonography has not given me the complete answers. I need to further evaluate on this. Dr. Gauri, would you want to make a comment on this? Dr. Meena Gauri?
Yeah, I'm here. So when there is a space occupying lesion in the endometrium, it's not just a uniform thickness, but looks like a mass. Then to assess the myometrial invasion, it can be done. If there are other masses in the uterus like a fibroid, which could also make the measurements difficult, and presence of adnexal masses, these are the situations where MRI is the next step logically.
Yeah. Thank you so much. So we now go to Dr. Manjit Mitra. Dr. Manjit Mitra, can I see you anywhere? Because I think we are not spotlighted.
Yes, ma'am.
Yeah.
Actually, I was a subdivision emergency.
No
That is why
problem.
I'm on my way back. Am I audible clearly?
Yes, you are audible. Thank you so much for being there.
I have turned on my camera. I don't know if I'm visible.
No,
So,
doesn't
yeah.
matter. We would like to hear to you and then maybe see you later when you reach your destination. So how do you
Yeah.
handle imaging and biopsy discordance in these patients? Because imaging is saying something, and we have experienced it so many times. That even especially we are doing so many medicated terminations also. The radiologist, or even if you do a sonography, you may see that there are very less products, but actually when you do a DNE, she's continuing to bleed, you find there's a lot of things coming out. Likewise, it would similarly happen in a patient who is coming with postmenopausal bleeding. And then what do you do when such a discordance exists? So can you just guide us here?
So yes, there are gynecological discordance, there are obstetric discordance. So if we take up the gynecological situations, yes, of course, like madam you mentioned about the postmenopausal bleeding patients, most often we find the reports they are suggesting that there is a thickened endometrium. And then we plan a hysteroscopy guided biopsy, we go in and we see nothing. There is atrophic endometrium. Maybe it was senile atrophic endometritis all through, but then we have unnecessarily put the patient through a procedure just based on the ultrasound report. So, of course, we need to be aware of when the scan was done, where the scan was done, whether a high frequency probe was getting used at that time or not. And we have faced problems otherwise also. Like the CVS has been done, just fairly saying that things are normal, but then uh, when we go in with the camera, we see that okay, there is a polyp, there is a polypoidal endometrium. Often it might so happen that the TBS had shown us something, and there is a thickened endometrium, maybe a polyp-like growth somewhere. And then we later come back, and the patient comes back with a biopsy report which says that there's nothing. I mean, it's absolutely normal. Now that can of course be a focal lesion which has not been sampled adequately. It can be a sampling error, that is on part of where the procedure was done, whether it was hysteroscopy guided or whether it was an office sampling or a blind biopsy. All of these contribute to the gynecological discordance that we see most often. So how to tackle them is like, of course, we have to be honest with the patient. We have to say that you have to go for a repeat biopsy if we do find that things are not corroborating.
Okay.
We have also got to take these factors in the risk factors of the patient. Like if the patient is obese, having polycystic ovary, like you said just now, diabetes, having unopposed estrogen, or even had been on tamoxifen therapy, and we are clinically quite sure that there might be some problem, but the radiologist is not confirming for the same. Always a good practice, like you said, madam, to have a clinical setup where there is an accessible transvaginal scanning facility with us, so that we can actually see and ensure what we are trying to evaluate. Even we have seen people landing in problem while doing myomectomy, maybe a laparoscopic myomectomy, and it was an adenomyoma all through. So you go around digging without even realizing. We have faced such problems not just with TVS reports.
Currently we are focusing on the endometrium. So I think your answers are absolutely something, an eye opener, that you have to look at typically what you told us about the red flags that the woman has as far as the endometrium is concerned. So these would be essential. Too many patients are undergoing screening sonographies for various reasons. There are some, insurance related issues, workplace issues, and they may not be the right thing or the baseline. And therefore you should ensure that it's been done in a proper way, and a transvaginal ultrasound done properly. Now, this is something I always don't like to say such things, because I feel when you're doing anything, it has to be standardized, but it's not always feasible and possible. And then maybe if there is such kind of a discordance, you may take a recourse of doing, so primary discordance, you will do a proper TVS, second discordance, you would consider an MRI, and maybe red flags, you would consider doing a hysteroscopy guided biopsy. Thank you so much, Mitra, for that wonderful answer. And now we come to Dr. Paushali Sanyal. Is hysteroscopy always needed if MRI shows deep invasion, Dr. Paushali?
No, actually, hysteroscopy, madam, is not always needed because MRI, if it is clearly showing an invasion, we don't need hysteroscopy, but there are some exceptions. For example, if we have the young women who require a fertility, like fertility preserving treatment if they want, like they have a very early stage endometrial cancer. Now, this is again, it's on the rise in India. Now, for these, now here, if MRI is giving a report, say for example, if it's showing a suspected or a superficial myometrial invasion, if it's some kind of this kind of a report comes, then we can go for an MRI guided hysteroscopic resection of the lesion, because that will give a more precise pathological diagnosis, because this lady later might require some hormonal treatment when she so this is one condition for young patients who wish to preserve their fertility. Again, sometimes if for focal tumors, if we need the focal endometrial tumors, then hysteroscopy, guided resection, that is of it is often required. Now that is again, we go for a direct sampling under visualization. So in such cases, hysteroscopy can be more accurate, even if MRI is clearly showing invasion. Here, if we go for a hysteroscopy guided removal of the endometrial tumor, this is where hysteroscopy is, it is recommended. And again, sometimes what happens is, if there are the reporting, if the MRI, the reporting is not very inconsistent. Suppose there has been an initial biopsy, the MRI report, as Dr. Manjir was saying, now there is a discrepancy between the MRI report and the previous previous histopathology report. Then in this case, for such ambiguous reports, we go for a targeted, biopsy, hysteroscopy guided biopsy.
Absolutely. So the entire spectrum of the woman's health has to be taken into account. Dr. Meena, if I may ask you this question, we are okay talking of hysteroscopy and we very efficiently, proficiently do it, and it turns out to be a cancer. What is the chance that we are upstaging that cancer by doing hysteroscopy? This is a very commonly asked question, primarily by the gynecologist and also felt by the patients, because they have a lot of access now, and today ChatGPT tries to give them answers as well. So what is the possibility that this can happen?
Logically, it seems that when we push water, saline, it sort of disseminates into the peritoneum. But then there have been studies which show that there is no difference in survival, whether we use hysteroscopy as a modality of treatment or diagnosis. So we still can use it as a tool for diagnosis.
Absolutely. So thank you. I hope the delegates are getting absolute clear answers, and I really want to put my claps here for all the panelists who have. So we have sort of come to this conclusion that TVS is an acceptable always first step, and remember to look at discordances. MRI may be preferred, and then look at the fertility pattern, as Dr. Paushali said, and then consider, because then you have to look at red flags of the patient, clinical judgment, clinical assessment, clinical detailing is never going to be replaced. And then you have to stage-wise use your imaging correctly so that you are able to give correct answers to your patients. Thank you so much. So now we move on to a little outside the uterus into the myometrium, fibroids and adenomyosis. 3D transvaginal ultrasound maps number, site, MRI for multiple complete uteri and structured FIGO 0 to 8 reporting, adenomyosis on an MRI, the junctional zone more than 12 mm or junctional zone myometrium more than 40%, plus minus intramyometrial cyst, plus T1 foci. Now, these are what the evidence snapshots at this point in time are saying. And I now have an expert here in the form of Suesha, who is going to speak, and then we will have another person talking to us. I've always revered what Dr. Kuldeep Singh says, and therefore I decided to put all the most complicated things here. And Dr. Kuldeep, I also want you to conclude for all of us at the end. If any consensus statements, if I am missing, please guide us. So this is a thing that I am giving you, so to help us with, so that we are able to steer the management of our patients well. So Dr. Suyasha, you are there. Can I have a look through? Dr. Suyasha? Is Dr. Suyasha Khanijo there joined on the screen? No? So then can I give this question to Dr. Meena? Can you take this question?
Yeah,
Dr.
sure.
Krishna is not there on
Okay,
the.
okay, fine. Doesn't matter. So pre-myomectomy mapping, 3D ultrasound or MRI first. So what would you tell us? Now you have a patient whom you have to do a myomectomy. It can be any one laparoscopy, or you are doing an open myomectomy. But you want to know exactly, because you want to plan it properly. You want to ensure, and usually we know we are doing myomectomy for fertility restoration most commonly. And you want to be very, very precise, not land into any problems. And especially if you're doing it laparoscopically, you have to be all the more careful. So what would be your mapping for this particular? Will it be an ultrasound 3D or an MRI first?
After the initial regular 2D ultrasound, I tend to go for an MRI because I think it's just a matter of practice. I've always relied on fibroid mapping with MRI. With 3D ultrasound, I've really not had much experience. Although I think in the hands of a good radiologist, a 3D ultrasound should yield the same, information as an MRI. The importance of this is to plan the mode of surgery, and then the depth of the fibroid, all the practical steps in the laparoscopy to avoid entering false planes, prolonged operative time, all those things, and also to avoid damage to the endometrium, because when we know how close we are to the endometrium, it's always good to know that pre-operative than to go blindly and then search in laparoscopy. So sometimes a large submucous fibroid, it's better to remove laparoscopically for endometrial preservation than try and do heroic hysteroscopic resections. So I think fibroid mapping is essential. I tend to use MRI. I don't have much experience with 3D ultrasound, but then I think both of the investigations are good if they are done properly, to quote your word.
I want to ask you one catch 22 question, and I'm going to ask this to Dr. Kuldeep also. What about the fact that if it's a leiomyosarcoma?
This is tricky. It is a catch-22. So there are some tumor markers which probably can be done, but then they are not 100% reassurance. As MRI, yes, it gives us certain markers like raised vascularity, etc. But still, we are caught unaware during the surgery. Sometimes post-operatively, the biopsies come as a surprise. Loud slap on the face. Yes, we are caught like that. But we do know that evidence says whether it's morcellation in bag or without a bag. If it's a leiomyosarcoma, we are not doing any harm by doing the traditional procedures where we presume it's an innocent leiomyoma. We can still do things as per our teaching. And I think we need a better specific investigation to know pre-op diagnosis of leiomyosarcoma. That's where I think we are.
Yeah, so I know that's a very difficult one to take, and we have seen tragedies in our practices. And if not in ours, we have seen our colleagues suffering from challenges with these. And now we move on to, so thank you so much for giving us this answer. So you have said that you would start with a 2D transvaginal ultrasound. I would start with a 3D because I have my own sister doing my imaging, and so I'm really blessed. And I trust only her images. That's what has happened over a period of time. Probably she is always concerned that I should not get into problem. Must be, my judgmental opinion as well. And it cases due to its high accuracy, cost effectiveness, and accessibility. And of course, I would reserve MRI for complex scenarios. But yes, as you rightly said, you should be able to deliver the best for your patients. And even MRI 3Ds are available, and which we can take a recourse to and have a better answer. So now I'm coming to Dr. Kuldeep Singh with a question on adenomyosis imaging. what MRI criteria clinch diagnosis? And I know you're a sonologist, so you would speak on that. That also is fine with me. Because today we are speaking a lot about this MUSA criteria, which talks about the direct features and the indirect features and so many things. Could you just give us some practice points where we as gynecologists should be able to deal with this condition appropriately and not land up in challenges? Like one of our panelists did mention that we went into laparoscopically thinking it's a myomectomy, which we all know the planes are easy to do. And then we land up in a problem. Oh, it turned out to be adenomyosis, and worse still, it turned out to be leiomyosarcoma. So the screen is all yours, my dear.
Thank you, ma'am. Thank you. Thank you, Dr. Archana. Thank you, Dr. Girja. Basically, I'll just answer the question which was there beforehand, which you had said about leiomyosarcoma and leiomyoma. If we're doing a follow-up of the ultrasound and we've been following up a patient and we all of a sudden feel that there's a rapid increase in size, plus with a mixed echo pattern or an inhomogeneous fibroid, I'm looking at which should be ideally less vascularity, but I'm seeing more vascularity. I'm going to strongly suspect that I'm looking at a leiomyosarcoma. So one thing is for sure, we're never supposed to be giving a histopathological diagnosis on imaging. So that's definitely there. So once we are through with that, once we've seen a patient for the last 5 years, 6 years, and we see all of a sudden it was, let's say, 24 millimeters, 25, and now last year also it was around 30, and now it's becoming 60 millimeters, I'm going to be very, very cautious. Then coming on to this question which you've asked, I'm going to first let you all know the ultrasound features. But before that, the moment the patient comes and we're taking a history, we're going to be thinking of adenomyosis. The moment I put on the probe, I'm going to be thinking of adenomyosis, not that I start off with all the features of, it could be an enlarged, globular, bosselated uterus, the same thing that ma'am is showing over here on the MUSA guidelines, and that's a lovely way of looking at. If you're looking at the anterior myometrium, which is less thinner, and the posterior myometrium is much more thicker, you're looking at myometrial cysts. You're looking at a junctional zone, which you can see nicely on the 3D as well, where you're looking at an asymmetric thickening of the junctional zone also. The other thing, you're going to look at a salt and pepper appearance. You're looking at a Venetian blind or a rainforest appearance. You could be looking at adenomyomas, and the basic difference between a leiomyoma and adenomyoma is on 2D, you're going to be looking at sharp features or sharp margins in a fibroid. The moment you switch on your color Doppler, and sometimes I need to do a power angio on a fibroid or a leiomyoma, you're going to look at peripheral vascularity. In an adenomyoma, it's going to appear as if there is a stream sailing through. What we have over here in the morphological uterus sonographic assessment MUSA features, we have these direct features of looking at myometrial cysts, hyperechoic islands, and we're looking at echogenic subendometrial lines and buds. That's basically the salt and pepper. Indirect features which tell us because of adenomyosis, all these things have happened. We're looking at the fan shapes, asymmetrical thickening, a globular enlarged uterus, irregular junctional zone, and sometimes an interrupted junctional zone. Then when we need to be doing an MRI, sometimes you're not very, very sure and you need to do an MRI. Then the first and foremost sign that is there going to be is a junctional thickness, zone thickness of more than 12 millimeters. Then we have this ratio over there, where is the junctional zone myometrial ratio over there, which if it is more than 40%, that's when we're going to again think on. I checked with my friend and he sent me all this because me doing ultrasounds. So I checked with the radiologist friend and he told me all these. And if you're looking at a difference in the junctional zone thickness between the anterior and the posterior portions, which is greater than 5 millimeters, I'm going to again think. But the only criteria in this of greater than 5 is that the junctional zone should be between 8 to 12 millimeters. We can always have gray areas, but again, ultrasound plus MRI, both of them are equally in terms of the sensitivity. Transabdominal scan is not very sensitive, but it is definitely specific for finding out about adenomyosis.
So thank you so much. And I think there was a caveat recently. It indicates that sole reliance, as you said, on the junctional zone thickness may miss some cases. Thus, it's crucial to combine measurements with morphological irregularities and focal lesions. And it was so nice of you to consult your radiologist friend and give us these small tips, because many times patients come with MRI reports and we ourselves can read them and take. We have a practice in our own university hospital where I go and sit on the console with the radiologist and do the proper mapping myself, especially in very complex cases, and we are lucky. But not all of us can be so fortunate. Sometimes you have to look at the films and make these interpretations, and thank you so much for giving us these insights. So MRI can be better than ultrasound when fibroids are numerous or complex. Structured FIGO classification aids planning. And adenomyosis MRI criteria and pitfalls have to be looked into, and definitely avoid menstrual phase pseudo thickening, distinguishing internal from external adenomyosis, and this can be a practice point. Now let's move.
Dr. Girja, sorry, can I just add one thing? Sorry.
Of course.
That's again from a radiologist friend. He had given me the step was that the MRI contrast is not needed for adenomyosis. That's for sure.
Okay.
It does not give any better. Yeah.
Absolutely. So there no additional information by taking a contrast, and that's a wonderful thank you message from you. So anything, please, all the panelists feel free to give all the answers, any suggestions. It's highly likely that I may miss something very important while I'm moderating this session. But all the same, it's nice that we heard such insights from Dr. Kuldeep. So now we move out of the uterus, come to the tubal versus ovarian mass. And hydrosalpinx, where we know that it is a thin wall structured, which is usually a C or S-shaped, incomplete septate, beads on string. Pyosalpinx can be a thick wall debris. Cogwheel C sign may become tubo-ovarian complex. And there can be indeterminate after expert ultrasound, MRI. Maybe you may have to follow ORADs for risk and follow-up in these conditions. So Dr. Kuldeep again, so what are the tubal versus ovarian mass key ultrasound signs that you can give us guidance about and tips about? And what would be your algorithm to follow so that we don't make mistakes?
We all always think that transvaginal has a better resolution, so we always should be doing just a transvaginal. That is something we need to be careful. The first time the patient comes, we need to be patient and we need to be filling up the bladder. So that sometimes if there's something which is higher up and you're not able to figure out, because the transvaginal ultrasound has higher frequency, better resolution, but a lesser penetration. And you cannot be maneuvering your transvaginal probe as much as you can maneuver a transabdominal probe. The moment you're looking at any adnexal mass, you have to see whether is it connected to the uterus, is it connected to the ovary, can I see the ovary separately, or is it just that a tube and the ovary? So whether is it a tubal mass, an ovarian mass, or a tube ovarian mass, that definitely has to be sure on. We have to. So to figure out whether it's ovarian or non-ovarian, whatever mass you see, if you see a rim of ovarian tissue around it, you're sure it is ovarian. If you are going to be with your transvaginal probe pushing it, and you're going to be doing a slide thing, and if you find that that mass and the ovary are moving separately, it's non-ovarian. Otherwise, it is an ovarian mass. Then various signs where you can see a beads on a string sign, a vase sign, a cogwheel sign, but then a pattern recognition for looking for ovarian masses is definitely there, as Dr. Archana ma'am told us. That if you're looking at a simple cyst, these are the features, a hemorrhagic ovarian cyst, whether it's acute or chronic. If you're looking at a clot, always looking for concave margins because it is a retracting, then an endometrioma, then a dermoid. All the others you're going to be looking at as indeterminate, and you're going to strongly think of malignancy. Not that they're all going to be malignant, but be very, very careful of. Think of those possibilities, and it turns out to be benign. We all are going to be happy about it. In terms of malignancies, be careful of looking for septi, especially thick septi, any solid areas. And if they have a vessel, that means the danger signs are on. So that's how you're going to be differentiating whether it's a tubal mass, ovarian mass, or a tubo-ovarian mass. Looking at the contents inside, looking at the shape, looking at which phase of the cycle you're seeing, and we'll all be much more wiser on that.
Thank you so much, Dr. Kuldeep. I just wanted to know what about the ORADS classification, which has been spoken about. And as you can see here, I have put this as a figure here, and it looks to be very systematic. And it does give you a comparison, as you can see here, the ORAD score and the IOTA model classification, which we're using. There are certain lexicon descriptions, and then there are pre and post menopausal features, and there are certain specific terms that are used, and all these things are there. As gynecologists, how can we consolidate them in our day-to-day practice, and maybe demands from ourselves if we are doing the radiology, or from our radiology colleagues?
Ma'am, all these scoring systems, the IOTA, the ORADs, the GYRADs, all these are basically what we're trying to do is, because we have a limitation, we can't tell the histopathology. So we're just trying to figure out which are the chances. We don't unnecessarily operate too many, and we don't unnecessarily leave a few of them, and we later realize we made a mistake. So this way, we're just trying to let them know, okay, these are the chances, whether I'm looking at a follicular cyst, corpus luteum cyst, the chances depending on the color scoring, whether I'm looking at more chances that it could be malignant. If I'm looking at areas inside, that's what ORADs, GYRADs, or the same thing as IOTA is telling us. I sometimes follow, and I find that much more convenient is the RMI, the risk of malignancy index. That's basically tells us about the CA125, the menopausal, postmenopausal, or premenopausal state. Those 5 things that you're trying to look at, whether it's bilateral, whether all those areas that you're looking at, and you just multiply them. And if you're getting a score of less than 25, you're quite comfortable. If you're looking at some books say 25 to 200 or 25 to 250, you need to be, because it's not clear, you need to get an MRI done. And if it's more than 200, or some books say more than 250, then you definitely need to do a staging CT, and then you need to be consulting a gynecological oncologist as well.
Yeah. So this is, I think, just a categorical way of doing things so that you do not miss, as Dr. Kuldeep said. And it's always better to document it in a proper fashion so that we are able to give proper treatment, and sometimes maybe proper explanations as well, because sometimes we may need to have counseling to the patient, looking at our treatment assessments and where we have reached. So we come to Dr. Mansi Vaish. When do you add MRI after an expert scan? So, indeterminate US findings or whatever are the reasons. Is Dr. Mansi Vaish there? Dr. Mansi? Dr. Mansi is not there? Okay, then I think the question again goes to Dr. Meena Gauri. I have found a pal in a panelist.
Dr. Mansi is not there.
Yeah, okay. So when do you add MRI after an expert scan? A scan has been done. When would you want to do an MRI?
If I have clarity with the ultrasound and the tumor markers, I wouldn't really need an MRI, because we will need a histological confirmation, and then we will proceed. So if it's indeterminate, in the sense if the tumor markers are borderline, or if the ultrasound is not giving me enough assurance that I can use a minimally invasive method to remove the mass, then I will go for an MRI. It's mostly based on the clinical scenario. I would use the MRI for making a decision, which route of surgery, or can I wait and watch, for those kind of instances.
Okay. So yes, we have already dealt with this, and we have to remember, as I said, so practice point is pattern recognition. As Dr. Kuldeep Singh said, you have to look at it carefully, and then you would reserve MRI for indeterminate masses, as Dr. Gauri has told us. Now let's go to endometriosis and peritoneum, another challenging thing. Now, the International 2024 consensus said the expert deep endometriosis ultrasound pre-surgery MRI complements mapping for bowel, ureter, and compartments. Structured descriptors such as triage to endometriosis centers may reduce diagnostic delay, and multi-society consensus has come up on non-invasive imaging classification for deep endometriosis, strong agreement on expert ultrasound, MRI for extent and especially compartments. So typically, we have always been talking about saying that laparoscopy is the gold standard wherein we try to see, because the superficial peritoneal endometriosis, which are not visible on imaging, will be able to see. While if it's an ovarian endometrioma, we are much satisfied and happy when ultrasound comes in. While deep endometriosis of sigmoid colon, probably it will have to be a complement between ultrasound as well as an MRI, and not only doing a laparoscopy, it may be just blinded to it. And therefore, if you are looking at this particular publication, which has happened recently, which probably led to the consensus that there is now a concept of doing a non-surgical diagnosis of endometriosis with proper imaging, and therefore ultrasound has come there very, very importantly, categorically trying to look at not only the medical history and clinical assessment of the patient, but also then using ultrasound especially, and maybe MRI if necessary, for understanding these diseases and trying to avoid surgeries, because they would not really give great results and you could still start her on therapy. So, Dr. Kuldeep, pre-surgical mapping, I would like you to throw a light on all these aspects of endometriosis, deep endometriosis, peritoneal disease, and everything that you have in your very, very eminent pockets. Please tell us.
See, for basically, we're looking at the infiltrating deep endometriosis analysis. We have the idea group, and they tell us. So they basically have those 4 gradation. I'm not going to talk in detail because then that will go on for almost half an hour. Yeah. But why are we trying to do this one, and what all can we see? So we first start with ultrasound, and then we come on to the MRI. We're first trying to figure out, am I looking at an ovarian cyst or not? So that's the easiest to do. The chocolate color, we're looking at homogeneous echoes. There could be a solid mass, which Archana ma'am beautifully showed. Then we're trying to visualize, am I looking at any adhesions? So I'm going to be doing a sliding sign to looking for, is the uterus adherent? Is the uterus and ovary adherent to each other? Is the uterus and the cervix basically any adherence to the rectum behind, or any adherence to the bladder? Then we're trying to look in for where could all these areas be, the lesions be. So basically, we're trying to find out the size and the depth of the endometriotic implants, the deep infiltrating. And why is this beneficial? Because ultrasound has a different sort of benefit. MRI has a different sort of benefit. We're going to be having a good surgical planning. The surgical outcomes are going to be better because we know what we're trying to do, where we need to be doing, and the patient counseling is going to be really better. Okay, we're looking in this. This is always going to happen. This could be the duration of surgery, which could always change, but at least you know if it's going to be a complex surgery or not. You can prepare the patient and yourself for complex cases, and obviously then we have a cost-effective screening. Basically, what we're trying to do is we're trying to figure out, earlier on we used to say either I see an ovarian cyst and that is it. Now it is looking in for the DIE, deep infiltrating ones, looking at the rectum. You could be looking at the ureters as well, where we could be looking at any hydronephrosis. But the MRI is going to be giving us a little more information by looking at the nerves, which could be difficult to assess even by laparoscopy. So we have this high resolution imaging in MRI as well. We have the localization of the lesions, the assessment of the nerve involvement. That's what my radiologist friend helped me out with. Then the other good thing about an MRI is it can differentiate active disease from scarring. Yeah. It can tell us whether am I looking at active endometriosis or is it a scar tissue from a previous surgery. And a complete pelvic assessment can be done as well. So this is basically when we're trying to figure out, and we have this scoring system also. We have the idea, otherwise we have the endometriosis, what do we call it, surgical ultrasound system, where there's a standardized approach to document the lesions in the pelvic compartments. How much is in the adnexal, how much in the anterior, how much in the posterior, and how much in the pouch of Douglas. So once we know about all this, we are going to be much better prepared. So that's first line. Again, we're doing a transvaginal, as you've correctly done over here, ma'am. MRI, whenever we're looking at multiple compartments, whenever we're trying to, let's say we need to do a surgery, we first do a laparoscopy and then we figure out, no, there's plenty of bowel involvement. If we knew about it earlier, we could have had a surgeon from the other side as well, a gastrointestinal surgeon. So in terms of operating again and again goes down, and plus we're going to be giving a much better result to the patient. So it's a teamwork, it's a team approach.
Absolutely. Thank you so much. So all of us have to remember that we need not do surgical diagnosis anymore. We have such wonderful imaging patterns. Those have to be evaluated before you decide. And if at all you're going to do laparoscopy in endometriosis, it has to be with the therapeutic approach and not a diagnostic approach. So thank you so much for that wonderful insights. Now let's come to Dr. Paushali. I'm sorry. So, how do you report peritoneal involvement for the surgeon, or now how do you expect that it should be reported? If you are doing your own ultrasounds or if you are expecting it from a radiologist, how should it be properly done and why it would matter?
Yes, ma'am. So basically, the idea protocol is there. That is there should be a structured reporting format actually. Now there should be a template. Now, first of all, you need to specify the type of scan, where transvaginal scan, whether you have used any bowel preparation. Then, as sir was saying, go and report regarding the lesions, whether it's a nodule, whether it's there's a plaque, which is on the. It should be compartment wise. Like the anterior compartment is the uterovesical pouch. Then we have the middle compartment, whether there is any lesion in the uterosacral ligaments, and whether there is any lesion on the posterior compartment, which involves the pouch of Douglas and the rectosigmoid. So here we need to we have to give the structured compartment wise a report. Now that has to include the the size of the lesion, the vascularity, then what kind of a lesion, as I said, it is, the location. And then again, after that, you need organ-specific findings, because the peritoneum is actually covering the entire all the organs. So we need to go to the admixture. Then we need to see the sliding signs. We need to see whether there are kissing ovaries, because that's important. And you go for the organ-specific findings. What is the appearance of the uterus, the ovaries, whether there is any lesion on top of the dome of the bladder, whether there is any lesion on the bowel. We need to give the extent, of the invasion, whether there are deep lesions, because deep infiltrating endometriosis is something that is very much on the rise. And if there is deep infiltrating endometriosis, we need to refer the patient, before experimenting, we need to refer her to an endometriosis, centers, where there will be multidisciplinary approach, because we need bladder resection, we might need bowel resection. So this is how it should be reported. As I said, then mobility, whether sliding sign is there, whether the ovaries are mobile. Now, ultimately, after compartmental reporting, then reporting on the organ-specific reporting, this should be a structured format. After that, we need to give our conclusion. So this is how peritoneal endometriosis should be reported based on the consensus.
Thank you so much, Paushali, for reiterating certain very important points that both of you discussed. And now we come to our very India-specific, not to be missed out, mimicker of endometriosis, and which is also malignancy in India sometimes, the genital tuberculosis. When we see that maybe we have completely done with it, we know that it is very much there and keeps on hitting us in our clinical practices, causing a more challenge. At the end of the session, if I have time, I can share you one terrible case, but then for lack of time, let's move on with our panel right now. HSG, we have learned beaded tubes, isthmus ampullary blocks, and on ultrasound and MRI, we would be able to identify the various complex things like hydrosalpinx, necrotic nodes, etc., or nodular peritoneum, and then combining it with microbiology and the clinical risk assessment. And we all know that it is a paucibacillary imaging pattern across these various imaging techniques which guide our suspicion, and peritoneal tuberculosis often mimics advanced ovarian cancer. So I come to Dr. Jayashree Sharma, imaging clues that tip you to female genital tract tuberculosis versus endometriosis or carcinoma. Can you just throw some light on this, please?
Yeah. That's a good question, actually. As you told, tuberculosis is very common in India. And most of the times, the history is the one which will really help us to clinch the diagnosis, whether this is endometriosis, tuberculosis, or we are dealing with the cancer. So that's what I think. But of course, when we see in ultrasound, when we see the uterus, so how we see, first we see the uterus. So if it is a possibility of, if I see any in the endometrium, if I see any adhesion like Synec or if there is a fluid collection, possibility of this Cox disease comes in my mind. But the walls of the uterus is fine. And suppose, so this is a possibility of tuberculosis. And in the adnexa, if there is a adnexal mass, complex mass, and the ovary is not seen separately, and there is a necrosis, necrotic areas and calcifications, this all goes towards tuberculosis as well as ascites. And sometimes because of this fluid, we can see adhesions also. Even the bowel adhesions adhering to the anterior wall also, we can see if there is a good amount of fluid. So, and the other thing is, suppose if it is an endometriosis, of course, we may be used to the endometriotic picture very easily. In the uterus, inside the uterus, endometrium may be normal. And I can see the walls of the uterus, sometimes that may be associated adenomyosis also, the thickening of the wall, like how Kuldeep sir has nicely shown that MUSA pattern, that scoring. The posterior wall is mostly involved with the thickening. As we were discussing, like everything has come, the younger ages started getting, we used to say only the adenomyosis disease of at the age of 40, but now we are seeing even a younger age group, they do get this thickening of the posterior wall adenomyosis and the proper history and problems also. And the associated endometriotic cyst, most of us will be able to diagnose with the low-level internal echoes or the ground glass appearance of the endometriotic cyst, multiple cysts, and mostly it will be bilateral. And the tube also may be that both the abdomen, the tube and ovary may be together. It may be a complex mass together. And sometimes, as we were seeing many pictures, you yourself has shown and Archana ma'am also shown, like both the ovaries may be sitting together, kissing ovaries, and that this glass appearance, like cooling glass appearance behind in the pouch of the Douglas. Those things will definitely point towards the endometriosis. And if it is CA, definitely the age matters, and then the history. All these things only will make us suspect maybe it is going towards a malignancy. So if it is an endometrial, of course, first itself we have seen the thickening of the endometrium, now, particularly in the postmenopausal people or in the younger age group. If we are not able to see that, we used to see in the sagittal section nice anterior and posterior endometrium, or sometimes during the menstrual cycle, if we see the 3 lines sign, nicely we can delineate the endometrium. Suppose if we are not able to delineate the border, if there is an inversion or if it is an irregular, definitely it gives a suspicion. Or if there is a polyp in the reproductive age group, definitely we know it's a polyp. But if it is going beyond the reproductive age group, possibility of a malignancy. Of course, fibroids, as we were discussing, whether this is a fibroid, is a myosarcoma or not, definitely that's a question. But LDH gives some, particularly the fibroid is, as Sir was telling, fibroid is growing very fast, vascularity is quite high, and the borders are not clear, and the LDH is high, definitely it's going towards a malignancy. So this is in uterus, and of course cervix we should not forget. Cervical malignancies, personally I feel it's difficult to diagnose with an ultrasound. Maybe Kuldeep sir, I want his opinion also. But suppose if it is going up, growing more, or if it is infiltrating into the uterus, maybe we'll be able to find out with the walls pattern, the heterogeneous shadows and increased vascularity. If we go to the adnexa, again, there may be ovarian mass, which are the iota scoring with that, we can make out. Definitely, even if there is a ground glass appearance, fluid, and if it is solid cystic pattern, heterogeneous, the papillary projections, definitely it will project towards cancer, I feel. And of course, ascites, again, it can be a sign of cancer. So these are all the things that comes in my mind if we want to classify. Of course, the history is the main thing, age of the patient. If there is a family history, patient, whether she is taking any HRT or not, particularly the pain, when we are doing the ultrasound, how the patient is, she's having pain in particular area, as Sir was telling, the sliding, all these things will help us to come to a diagnosis. But definitely we can make only a differential diagnosis. Possibly this is the first one, is possibly an endometriosis. If there is infertility and associated things, endometriosis and tuberculosis comes first and second. And then there may be a history of ATT also. If we probe them, then they may be telling us, yes, I was taking ATT like that. And then the third will be the malignancy, I think.
Thank you, Dr. Jayashree, for a wonderful, elaborate answer. And I would definitely agree to you, and I have learned in my practice, especially if historically this person is a medical personnel, a nurse, a doctor. I always will have first suspicion of a tuberculosis whenever there is some sort of an ambiguity. So, Dr. Kuldeep, she's asked you a question and an opinion. Would you want to answer that?
Can I have the question because I wasn't able to understand the complete portion? Dr. Jayashree, could you just repeat the question,
Yes,
please?
sir. That cervical CA, have you diagnosed in ultrasound? Because I personally felt I was not able to diagnose. Only by looking from down, I have seen. Have you diagnosed in any patient by ultrasound
No,
cervical CA?
it's not. It's quite difficult. The other way, what we've started now doing is we've started using lots and lots of jelly, and then trying to understand and trying to really watch out on the cervix. If the margins, there's a problem. The other thing is you have to be careful if you're looking at any mass inside the cervix, whether is it from the cervix per se or is it coming from above. Sometimes there's always a polyp. So what I've started doing is before I just go into one of the pharmacies, there's lots of jelly there, and then I always switch on the color. If I look in at a vascular pedicle coming from up, which is coming down, then I'm sure that this is from up to down. If there is something which is there only from the anterior to posterior wall, then I know that. I've been able to diagnose plenty of polyps in the cervix area, but looking at a cervical CA, well, by the time I diagnose it on the ultrasound, things have really gone bad by then.
Maybe it may be in the higher stage. Thank you, doctor.
Thank you, Dr. Kuldeep. Thanks a ton, and Jayashree. Now let's come to the uterine AV malformations. We all know nowadays they are quite on the rise, maybe because the radio diagnosis has become very, very high resolution, or maybe we are doing a lot of things on the uterus, which we may repent a little later in the form of surgery, curetages, or whatever diagnostics. We really do not know the answers. But then it is something which the radiologists have definitely taken over, and they would then go and do an AV malformation diagnosis, go and do an UAE, and then the patient doesn't respond to anything. She comes to us, and then we keep on wondering, what are we going to do with these patients? Now, there are certain thresholds which have been identified, and then there are certain questions. Like if you have done an UAE, what about the fertility of this patient? So the question comes to the maestro, Dr. Kuldeep Singh. Doppler versus MRI thresholds, embolization versus observations, and the screen is yours.
What happens is we've changing the nomenclature a little bit from doing on AV malformations. We've started making it EMV, that's enhanced myometrial vascularity.
Wow.
So we need to be very, very watchful because we've realized there are plenty of AVMs which you used to feel were nothing but just a little bit more or a little more of the vascularity in the myometrium. And we were unnecessarily getting fussy and we were doing more and more harm rather than good. In terms of if I talk about, yes, it's a diagnosed AVM. We know in the AVM, we are going to be looking in for what? It's a high velocity flow. There has to be low resistance. There's going to be turbulent flow and there's going to be arterialized venous flow. That's what AV malformations is all about. But there are plenty of AVMs, so-called AVMs, which have a low flow characteristics, meaning the peak systolic velocity is lower. And for uterine AVMs, we feel if it's less than 40 centimeters per second, we're quite comfortable. A high resistive index, if there's something more than 0.50, we're comfortable. So if it's less than this, we are going to be thinking of an expectant management. Embolization only if you're looking at symptomatic and it's progressing and you're looking at a very high peak systolic velocity, as ma'am is shown here, where you're looking at more than 50 or 60. In fact, the book now says if it's less than 40, nothing to worry. 40 to 60, keep on watching, might be. And if it's more than 60, then you're going to be thinking of aggressive management. That's how they're planning and not. In terms of MRI, there are plenty of features which are going to be telling us, but then they basically have the Aruba trial, which is more on the brain aneurysms and brain malformations rather than over here. But what they always do on an MRI is they're trying to figure out whether are we looking at any microhemorrhages inside, any high blood flow, any venous anomalies, any associated aneurysms over there. And what they've started doing on an MRI is they're trying to figure out the tangled vessels. How big is the tangled vessels? They give a scoring, but again, that's more on the other portions, not too much on the uterus. But when you're doing an ultrasound also, we should try and figure out how much, or as we call it in Hindi, the gucha, how big is the gucha or the tangled masses, whether it's less than 3 to 6, or more than 6 centimeters. And that's how you're going to be deciding on what needs to be done. In terms of the MRI, where really we're going to be doing is if it is not very symptomatic, and plus we've now been thinking more of enhanced myometrial vascularity, it's much better to be a little more patient. If the patient becomes too symptomatic, then only think of a higher thing to be done or at a higher center to be done. That's when we need to go in for embolization.
Absolutely. So thank you. I think all the delegates have got absolute clarity in how it's very important to not to jump at the diagnosis of AVM. And now I'm coming to Lieutenant Colonel Sumitra Gujaraj. I'm sorry I've spelled you wrong. Is she there, Dr. Sumitra?
She was traveling, so she may not be there.
Okay, so if she's not there, can I put this question to Manjeer? Manjeer, will you want to take this question? Or Dr. Gauri? Who would want to take this question? What do you counsel regarding fertility after an UAE? Because this is what happens many times. Patients will come with uterine artery embolization. It won't be always in the context of an AVM or as EMV, as Dr. Kuldeep Singh has now told us. It may be for some other reason also which have been done. Yes, Dr. Manjeer? Yeah. You're not audible, idea. I think you need to increase the volume of your machine. You have unmuted yourself, but your voice is not heard. No, we are not able to hear you. So can we have Dr. Gauri till Manjeer is able to make herself audible? Dr. Gauri, Meena?
Yeah, I'm ready.
Yeah.
So I would look at this counseling akin to permanent sterilization, permanent family planning method sterilization. The intention is to have no further children. But then if they do happen, that kind of a scenario, the same counseling. Uterine artery embolization is not to be done for someone who desires fertility. But then if it's been done previously, and then we talk about fertility, we do know that there are chances of reanastomosis, the uterus gains back its vascularity, etc. And there have been live birth rates. It's not something that we will do as a plan. So that I will make it very clear. That's the only thing I have to offer for this question.
Okay, no problem. Anybody else would want to comment on this question? Dr. Kuldeep, Dr. Manjeer, Dr. Jayashri, Dr. Paushali.
One another thing is, I have seen one case of uterine necrosis following a UAE, and that was very, very bad. And then we had to do a hysterectomy, and there was the shape itself was not there. There was just necrotic tissue. So after seeing that, I really wouldn't encourage anyone to go for this procedure if they have fertility in their mind, even in the back seat. So that is just from practical experience. What I've seen is just 1%, but then that 1% is 100% for that person.
Absolutely.
Yeah.
I have a couple of patients' experiences with UAE done by the radiologist and then coming back with abnormal uterine bleeding. And what worked was the DEMPA, the depot-medroxyprogesterone acetate injections worked for them. But then I think I've been plain lucky. Not always it would work. And then some of them are really desiring to get pregnant later on, but that time they want to take a recourse of these problems. Dr. Manjeer, have you found your voice? Dr. Manjeer Mitra, you would want to say something? Yeah, I think when you put off your video, you are able to speak.
It's like the challenges of trying to work from a hospital. So yeah, basically it was all unplanned. I'm so sorry for this emergency. Okay. So the thing is that okay, this is a very newer modality that we are talking about. UAE, we do not have enough data exactly to reflect on that, whether successful pregnancies have been there or not. That is why there's the general connotation that once you're done with the family, that then only we should go about going for UAE. But actually, in real life cases, there has been case reports where there have been a UAE, and after that, the patient has actually conceived. So because the pool is generally a smaller pool of data, that is why probably there is a lot of counseling going on that you should only aim for UAE after you have your family complete. But that is not so the case, I believe. At
Yeah.
least, obviously, it is a better fertility preserving option when we compare to hysterectomy. And in many cases, maybe that is the only recourse that we can take at that point of time, considering the various factors. Not that we are doing UAE every day, right?
So now you have done in UAE, you must tell the patient that be careful, you may still get pregnant. So I think that also can be a part of our counseling. Now we'll quickly come to the last aspect of our Mullerian anomalies and Asherman syndrome. We have understood that Asherman's continues to be a gold standard diagnosis by hysteroscopy. And then transvaginal ultrasound and MRI, especially for complex ones, is important. And classification plus descriptive reporting is known to improve communications. And that is where we have. So we have Manjeer, this question is yours. So when escalate from a 3D ultrasound to MRI for anomalies? You have an anomaly on your hand. How will you go about it? What will be your algorithm?
Okay, so the first and foremost, when we are suspecting, when we are thinking about an anomaly, like clinically, we are thinking it's somewhere like maybe a biconjugate uterus, a uniconjugate uterus, something like that, if you're thinking clinically. And then we are having a clinical picture where there is, an obstruction in the vagina or there is a cervical problem that we are being able to assess from a bimanual examination. So if we're already getting a problem in the vagina itself or in the cervix itself, I think a better choice would be an MRI at that point of time. If we are not finding any such difficulties, then maybe we can go with a 3D TVS, the ultrasound, that is, unmarried and all those difficulties are there in our way. Now, there are certain situations where, there's a syndrome like obstructed hemivagina with the renal anomalies, the horseshoe kidneys, ovira syndrome. If we are thinking of something like that, maybe then of course we can go straight away, go for an MRI and, get all the organs assessed that way. So, apart from that, I think these are the most common situations. Even for the surgical situations, we would want to go with the MRI mapping rather than going ahead with the 3D TVS, unless we're absolutely sure about the quality and that we can 100% rely, like if you're lucky like you, ma'am.
So yes, so all of us agree that we would always want to take a recourse of an MRI only if we have challenges, but we would always depend firstly on our ultrasound reports. And I think Dr. Sumitra is not there. Dr. Meena, can you take this? I'm going to ask you one more question after this, and I think that's going to be our conclusion consensus. Preventing recurrence and counseling in high-grade Asherman's.
Okay. Preventing recurrence is to have an adhesion barrier. But then since we know this condition is notorious for recurring, we do know that. And supplementing hormonal estrogen supplementation for promoting endometrial growth is another thing. But then it's known to recur. So using a adhesion barrier like a Foley's immediate post-op or a intrauterine device like Mirena, not Mirena, like a copper T, that will be helpful, that we can do. And of course, by finding the pathology, what is the etiology? So when there is COX, that has to be treated, even though it's the aftermath. And then doing a check hysteroscopy is something that is done in select cases, because soon after, if we find adhesions happening, then we have another opportunity to reduce the recurrence. Yeah.
What about the hyaluronidase injections which have been spoken about? Anybody has an experience? You do a hysteroscopy for an Asherman's and then you put in a hyaluronidase injection so that it's, because recently I went to Figo, there are so many stalls were there which were recommending such kind of a thing, and they did mention that it's not yet available in India. Does anybody have any experience about this?
No, ma'am.
No,
No,
so
ma'am.
no
No experience.
Yeah, and Gauri, Meena Gauri, I'll also want to ask you a question which we have missed in this panel discussion. Anybody, of course, can answer this, especially the diagnosis of a polyp. Many times, your high resolution ultrasounds will tell you a 2 mm and a 3 mm polyp. So many times we have seen pregnancies happening with a polyp side by there. And then a question comes, what do I do now? She has a polyp, whether I go in with a hysteroscope or should I do something else?
Okay, if it is in pregnancy, then we would do
Not in
it.
pregnancy, let's
I mean,
say.
otherwise, yeah.
Okay, yeah.
See,
Because today we are not discussing any pregnancies, what Dr. Archana told me. So it's
Oh,
only gynac.
okay,
Yeah,
pure
true.
gynec.
True. I said it's gynac only.
Yeah,
Yeah.
one word about Asherman's. In Asherman's, the real treatment is prevention. Overzealous curettage needs to be avoided. I think that has to be said as and many times as required. Getting back to the question that was asked, any polyp that we see, the instinctive thing is to remove it to rule out a malignancy. That's number one. Second, it could present as an intermenstrual or an abnormal bleeding or a fertility seeking patient. We don't want anything in the cavity which could prevent a pregnancy. Even though the chance of a malignancy per se in the reproductive age group of a polyp is very less. In this era where there's a lot of PCOS, hyperestrogenism, obesity, and when we talk about picking up endometrial cancers in a normal, in a uniform thickening, when we see a polyp, we would have to remove it to rule it out. And sometimes we see polyps on ultrasound, even with the saline infusion, we see nice contour, everything. And when we go and put in a hysteroscope, we see nothing. Those surprises do exist. I don't know what is the best way, but at the moment, when we see a polyp, it's best to recommend a removal.
Yeah, they're coming
We'll
up
stand
very
by that.
commonly. So anybody else would want to throw a light on polyp? Because I know that I'm sure the delegates would want to know. Because sometimes they are very small and you feel अभी इतना सारा hysteroscopy वगैरह क्यों करना है इसके लिए?
Adding a Doppler, I think when there is vascularity, a separate, a feeding vessel, that may be one pointer where we could consider using it, but I don't think there's any established system for classifying which polyp to remove and which not. Maybe days to go.
Can I add one thing, Dr. Girija, here for the
Yes,
polyp?
yeah.
You know, if it is a symptomatic, like if a woman is presenting to you with irregular bleedings, or maybe postcoital bleeding sometime, or postmenstrual bleeding, then yes, of course. But if it is only on ultrasound, you are scanning for some other reason and you just find it accidentally
Incidentally.
a polyp, maybe you can follow it up, and maybe next cycle, if it's a very small polyp, it might disappear. So you have to really weigh situation, individualize it. I mean, you cannot have a just a thumb rule that all polyps need to be removed. So I think what we do is just follow it up if there's no symptoms, or if it's a very small polyp, less than say 1 centimeter, between 1 to 2 centimeters. If it is 2 centimeter plus and the patient comes to us with infertility or with the intermenstrual bleeding, yes, then we remove it.
I think they have come to the consensus, and most of these things have already been reiterated and spoken about by the wonderful panel that we had today. And I want all of you to put your hands together and give them a round applause. I know it's not going to be heard here, but I would really want to clap for them. And especially, I am very grateful to learn a lot of new things also here myself, like the EMV, enhanced myometrial vascularity, then trying to choose MRI in the right place, and then trying to differentiate, and every one of us have found our own midways as maybe a proper reporting, trying to look at things, look at clinical, and all the panelists mentioned about clinical correlates, and also trying to use MRI if at all it is going to be necessary. I have not put in any thank you slide, and I am now therefore stopping my share as well, and I don't know how to do it. I think stop share. Yeah, I've done it.
Yeah.
So now we can have a full screen full of the panelists, and anybody wants to make any comments, you're please free. Next 2 minutes, I guess we have, because we have to now stop the panel. Yeah.
Thank you. Thank you, Girija. I think I learned a lot from the panel, and moderation was superb, and all panelists were superb. Means the contribution from each one of them was really great. And I'm sure all the delegates who logged in or those who stayed must have learned a lot. And I'm sure we are becoming wiser in terms of gynec ultrasonography by the end of this panel.
Thank you very much. It was wonderful to be a part of this panel. And as ma'am was telling, Archana ma'am was telling, I am very happy. No, from the starting, she was telling, don't do any unnecessary procedure. Always think the physiological thing. And that's the important information, particularly for the junior ones and the junior doctors and PGs. And I am very happy that that ethical practice is still there. Almost the whole of the panel, I felt it's quite ethical, all the answers and nothing, nobody was telling that I will do. So I'm really excellent panel and Dr. Girija, superb. I am just thinking, why my sister, I didn't make her a doctor, radiologist.
I'm lucky one. She's a fan of Kuldeep Singh, so I said, you please join. You have to listen to what he's saying.
Really a superbly moderated panel, Girija ma'am. Very amazing. The way you guided the questions. We didn't know from the endometrium when we landed up till the adnexa. It was such a smooth flow and great inputs, really great inputs. So for the vote of thanks, I would call upon Dr. Manila ma'am.
Just a moment before that, we want to hear whether Gauri, Paushali, Dr. Kuldeep want to say anything.
Yes, we would definitely want.
Yeah, few seconds.
I think today's session has been an example of theory of relativity. For me, time just flew. I could have sat all through the night, and it's such a pleasure hearing from all of you. So much of learning, reinforcement, unlearning. I think I'm very grateful for this opportunity. Thank you.
We also have Dr. Shailesh Kore. Sir, can you, we would like to have your input also on this at the end, this panel. Dr. Shailesh Kore, sir, are you there?
I think Geeta was supposed to stay as well.
I think it was a very well conducted by Girija, the panel, and even the answers or the inputs given by the panelists were very crisp and a lot of take-home messages. I think even we, many seniors members, and even the most of the delegates who have attended are much wiser as far as the gynec or adnexal ultrasound is the interpretation. I think so. Thank you, Girija, and thank you everyone for such a wonderful panel discussion.
Congratulations to you.
Archana, yeah.
For becoming the president-elect of MOGS.
Thank you, Girija.
Thank you, Dr. Shailesh. Thank you so much. I really enjoyed and appreciate all of you for giving your time.
Dr. Kuldeep, want to say something?
Yeah, absolutely. Thank you, Dr. Girija. That was really nice, really smooth. We really enjoyed from ultrasound to MRI to treatment to the dilemmas. That was really nice. Thank you, Dr. Archana, Dr. Rupali, Dr. Manila, Shailesh sir. Thank you so much. And the panelists. The only thing if there are delegates, otherwise this is going to go on YouTube. We need to be very, very careful when we are introducing the probe, when we're doing a transvaginal. One, because we should not be freezing the button. Two, we should be very gentle, because if we are trying to be asking the patient about probe tenderness and we're going to be rough with the patient, we're not going to realize whether it's true tenderness or this is we've caused that tenderness. So we need to be very watchful. The other thing which I wanted to give as a take-home message is, if you're looking for ovarian pathology, the second, third day is the best. If you're trying to look in for endometrial pathology, do on for day 10 or day 12, because endometrial polyp, day 2 or day 3, you'll not be able to see it. We're all going to party that the polyp has gone away, and we later realize it's again come back on day 10. Because it's there only, it's just that it becomes so small, we're not able to see it. So small things that we're going to be careful about, and we all should have the confidence of, if anyone can do it, we surely can do it, and we'll be doing a fab job. Thank you.
Dr. Paushali, you want to say something?
Yes, thank you. First of all, thank you, Girija madam. Thank you, Archana ma'am, and thank you to the organizers of this event. It was really an enriching experience to be a panelist, because it might sound like theory, because actually all the practical aspects of the dilemmas in gynae imaging were discussed, because the quality of imaging varies from person to person. And what we should focus on. When I started my job as a gynecologist, what I used to see was the impression, what was written by the radiologist. But right now, if you see the scans and you go through the scans, you see the plate, you will not be in a dilemma. Now I do some of the scans myself. So thank you, Girija ma'am. The practical points were really well discussed. It has really been an eye-opener, and I'm so glad to share the dais as a panelist with eminent stalwarts like Dr. Kuldeep Singh, sir, and all of you. Thank you.
So I think at the end of it, I would want to thank Dr. Archana Basair to make my gray hairs function so badly. And as you said that I don't only speak about obstetrics, I can't because I'm a professor in MS, teaching postgraduate. So I better know all the stuff under the sky. So Rupali and Dr. Manali, thank you for wonderful coordination and helping us do this well. Thank you so much.
Thank you so much.
So as we come to the close of this session, AICC RCOG West Zone Focus webinar series on decoding gynecological imaging, it's my privilege to extend a heartfelt vote of thanks on behalf of the organizing team, me and myself, Dr. Rupali. First and foremost, our gratitude to the chair AICC, Dr. Purnima, for her constant support. Our guest of honor, Dr. Sheila Mane ma'am, chief guest, Dr. Sailesh Kore, for gracing the occasion. A special thanks to Dr. Archana Basair for her excellent and comprehensive talk on evaluation of adnexal mass. Madam, we thoroughly enjoyed it. Our heartfelt appreciation to our moderator, Dr. Girjawak, for skillfully steering the panel discussion and ensuring that the ideas flow in the whole aspect, and the esteemed panelists, Dr. Jayashri Sharma, Dr. Manjir, Dr. Poshali, Dr. Mansi, Dr. Kuldeep Singh, sir, you have given such important messages that helps us in our day-to-day practice. So we also thanks our chairperson, Dr. Geeta and Dr. Anusha, for their valuable insight and guidance. A word of appreciation to AICC RCOG West Zone team for their vision and creating this platform. And last but not the least is heartfelt thank to all the participants who are joining us this evening. And I myself thoroughly enjoyed this session, learning so much from all the stalwarts tonight. And have a wonderful evening. Over to you, Dr. Archana ma'am, for your last words.
I think you have said everything, Manila. We are thankful to everyone who has joined as a panelist, as a chairpersons, and our guest of honor, chief guest. And I would like to thank both of you for really coordinating events so well, Manila and Rupali. Really heads off to you. In spite of your busy obsgyne practice, you have been doing such a wonderful thing that connecting with everybody, everyone, and you really handpicked the panelists. So everybody, like from north, south, east, west, when we could get inputs from all of them. So thanks to both of you, and a big thank to Sudeep ji for giving us this platform and making our flyers and everything at such a short notice. And whatever we say, it gets done. So thank you, Farmed and Mr. Sudeep, for your constant support, for providing us with the platform and spreading the knowledge to our delegates and our Foxians. Thank you so much.
Thank you.
Thank you, ma'am.
Thank you.
Bye-bye. Good night. Good night,
Bye.
Ji. Thank you.
Looking forward for the next webinar.
Yes.
So next time onwards, Rupali, you should have your next webinar ready, and you can put the flyer of next on this one. So that's a challenge for you for the next thing.
Yes, आज रात की भी नींद उड़ गई.
Bye, ma'am.